2022. We are the subcommittee of the Budget and Taxation Committee. We're the subcommittee on Health and Human Services. We have 3 budgets that we will review today. In this order, we'll hear the DHS administration, then we'll do the MDH Prevention and Health Promotion Administration, and we'll conclude with the MDH administration. So good afternoon, colleagues. I know we've had a long morning already, but we want to get to the business in front of us. So we will start with our analyst, Grace Pedersen. Good afternoon.
Good afternoon. Thank you, Madam Chair. It's my pleasure to present the Department of Human Services Fiscal 2023 Budget Analysis. The budget decreases 6%, and this is mostly driven by IT expenditures, both for the MD Think project as well as the department's other IT systems. There is a small decrease in general funds reflecting the availability of federal funding to support the Maryland Legal Services Program. The federal funding is available from Title 4E reimbursement, which the department was able to capture prior to fiscal 2017, so this is kind of a new change in fund splits for that program. Before I get too into the budget discussion, I'm going to start with the department's performance measures. The Citizens Review Board for Children is budgeted within the DHS administration budget unit, and there's several measures that are evaluated each year, collected by the CRBC. Exhibit 1 shows the cases, the proportion of out-of-home placement cases that receive both appropriate educational services and appropriate physical and mental health services. So you can see that the proportion of cases that receive appropriate physical and mental health services are consistently lower than the proportion of cases receiving appropriate educational services. During pandemic years, there was a decrease in the proportion of cases receiving appropriate educational services, although the department has worked with the Department of Education to improve access to like technology that was needed while there was virtual schooling going on. But in fiscal 21, the proportion of cases receiving appropriate educational services didn't pick up despite this cooperation to improve access to technology. In fiscal 21, there's also a notable decrease in timely reporting of cases to both the local departments of social services or the courts. So DLS is asking the agency to comment on how it expects to improve the timely reporting and also performance for providing appropriate services to these cases. Now moving to the budget discussion, in fiscal 22 there is a deficiency of $5.3 million to support the MD Think Medicaid application. The Federal Centers for Medicare and Medicaid Services requested that DHS streamline the Medicaid application, so that funding will support that, that development. Now in fiscal 23, just about half the budget is for the Office of Technology for Human Services, which is funding those IT systems that the department uses, including the systems developed by the MD Think project. The next largest chunk of the budget is for personnel. In Exhibit 3, this shows the individual fluctuations in the budget, and if I scroll down here, you can see a lot of the larger fluctuations are in information technology expenditures, the largest of which is a $23 million decrease from fiscal 2022 associated with application hosting and maintenance, and this is mostly driven by the legacy systems that the department was maintaining in fiscal 22 that are expected to be phased out in fiscal 23. So that hosting and maintenance expenditures will not be incurred in fiscal 23. Then going to personnel, the budget increases slightly because the turnover rate is reduced. So in fiscal 22, the turnover rate was budgeted around 7%, and then in fiscal 23, it's budgeted at a 5.4%. So even though the budgeted turnover rate is reduced, the department still has vacancies that are about double what is provided for in the budgeted turnover. So if I move to the issues. The first issue pertains to the department's vacancy rate. And Exhibit 4 shows the proportion of the department's positions that are filled on January 1st of each year throughout this timeline. So from 2012 to 2022, the lowest proportion of positions filled is seen in 22 with about 85% of positions filled. So this is a pretty notable vacancy rate considering the prior 10 years. And those vacancies are distributed mostly in social services and family investment administration. They consistently comprise more than 70% of the department's total vacancies. However, these are also the highest staffed administrations within the department. So that may be what's expected, but what's notable about Exhibit 5 is that over 100 positions were abolished last year. So even though the department has fewer positions, there's actually more vacancies going on, and that increases the vacancy rate. Looking at Exhibit 6, each administration had at least 86% of positions filled, with the exception of the Family Investment Administration, which saw almost 1 in 5 positions vacant as of January of this year. Now, Exhibit 7 is looking at the compensation for these positions that are persistently vacant. And this exhibit defines persistently vacant as positions that saw vacancy rates in excess of the budgeted turnover for 2 or more years. So this data is as of January 1st of each of these 4 years, and it's showing the salary range for each persistently vacant position. And you can see that the salary ranges for a lot of these positions are relatively low, with the minimums being less than $40,000 for most positions, with the exception of social worker positions. So social worker positions have relatively higher required credentials. They need to have a master's degree as well as a license. And so there's higher compensation for these positions, but they consistently join other classes of positions that see higher vacancy rates. So that could indicate there's other factors beyond compensation that may affect social worker retention. And during the pandemic, there were a couple studies of social workers' experience during this time, with some experiencing burnout, and each academic study had recommended that employers of social workers work to support social workers' like psychological and mental health needs, as well as kind of foster peer support groups. So in the past, DHS has worked to promote the professional development of social workers, and they have offerings to meet the continuing education requirements that are required to maintain a social work license, and they have developed training programs to kind of foster these professional development opportunities within the department for social workers. But given that studies have also found that social workers' well-being really impacts their experience and their role, DLS is asking the agency to comment whether it's prioritized any efforts to support social worker well-being, whether it's like facilitating communications between supervisors and subordinates, or creating peer support groups that have been seen to be important during the challenging workload that was seen during the pandemic. Then moving on, so I mentioned earlier that the Family Investment Administration sees a notable vacancy rate. And the department has indicated that those persistently vacant positions, they're family investment specialists. So these employees are working really at the point of entry to assistance to families that could be eligible for family investment services. And these employees each are required to have a bachelor's degree, but the department is working with DBM to reduce the educational requirements for these positions, and they hope that through this they could expand the applicant pool and improve retention in these positions. So DLS is asking the agency to comment whether reducing the educational requirements is expected to impact service provision at all, or the need for supervision of these employees. And then Another notable thing about the department's vacancy rate, especially during the pandemic, is that there were a lot of pandemic factors that affected the DHS's workload. So because there were child maltreatment reporting has declined, that caseload has declined. And then for family investment, there were a lot of temporary flexibilities in that program, such as pausing recertifications, as well as conducting interviews that reduce the department's workload in some areas and allow the department to kind of accommodate these lower proportions of positions filled. So DLS is recommending a report on how DHS plans to recruit for these vacant positions, as well as whether the vacancy rates are impacting service delivery, especially as the return to in-person schooling could see an increase in the child welfare caseload, and some of those temporary flexibilities for family investment programs are going to conclude. So now, moving on to the second issue. This is the department's major IT project, the MD Think. It's expected to conclude development in fiscal 22. And then it's all systems are planned to be moved into the maintenance and operations phase in fiscal 23. So Exhibit 8 is showing the status of each system that was in development. And what's notable here is the child support management system. This is the only position, this is the only system that was budgeted for development in fiscal 22. And that system is expected to conclude development in the current fiscal year by the last quarter of the year. And the decommissioning of the legacy system is also planned to conclude at the end of the fiscal year. So the department also plans, as of the second quarter of fiscal 22, about 8% of the statewide child support caseload was migrated onto the new system. So by the end of the year, they plan to migrate the remaining 92% of the statewide child support caseload. Looking at the funding and expenditures for this project, the department indicates that it is planning to receive more general funds through the conclusion of fiscal 22 than it's planning to expend. So in total, the project has received 111 million general funds, which have been appropriated to do its major IT fund. But expenditures of general funds are only expected to total 103 million. So that remaining 8 million is expected to just remain with the major IT fund to be used for other projects in the other do-it projects in the future. Okay, and going to the recommendations, the first recommendation is annual language restricting funding for the Maryland Legal Services Program to that purpose. The second recommendation is what I mentioned earlier for the department-wide recruitment plan. And then the third recommendation is to request reports about the different types of data that will be available with the new system. One of the major benefits of the MD Think system was like enhanced user features to improve service delivery, as well as improving data collection capabilities. And caseworkers are going to be able to enter field notes like while they're out and in the field, instead of having to come back into the office and enter those. So as there might be more data available, DLS is recommending to request a list of all that data that could be available for evaluation, as well as asking the department to comment whether there's any data reporting issues at the time this report would be submitted, and then when they expect those data reporting issues to be resolved. So that concludes my presentation. I'd be happy to take any questions.
Well, thank you very much for your presentation. A lot of information. We'll first turn to the subcommittee and find out if there are any questions from the members. Looks like there are none. So thank you very much. We'll invite up in person and not on camera, Secretary Padilla and your team. All right, good afternoon.
Good afternoon. And Thank you so much, Chairman Griffith and members of the committee for the opportunity to discuss the fiscal year 2023 budget allowance for the DHS administration. I have my team here with me today. Gregory James, Deputy Secretary for Operations, Subramanian Muniasimi Suvi, Chief Technology Officer, and Stafford Chipongo, Chief Financial Officer. Also available to answer questions as necessary are Dan Wade, Director of Human Resources, Denise Conway, our Executive Director for Social Service Administration, and Lashira Ayala, Executive Director for Family Investment Administration. I want to take the time to thank Grace Pedersen for her comprehensive and concise analysis. As always, excellent job. She's a pleasure to work with, and we appreciate all your support, Grace. You have my written testimony, and I will only take a moment to comment on the DHS administration. During the departmental overview and budget hearing, I testified about the mission of the department and the work and accomplishment of our programs. All of our department's vital work is supported and made possible by the administration units and the budget you're hearing today. Throughout the COVID-19 pandemic, despite teleworking and other challenges, DHS continue to deliver critical services to protect vulnerable children and adults and assist families and individuals in economic distress. Our front line and front staff are some of the many heroes of the pandemic. Today, I especially want to acknowledge and thank all of the DHS administration workers for their dedication and hard work to ensure that all DHS staff had the tools and resources necessary to work effectively from home or safely in the office throughout the COVID-19 pandemic. Without them, our work would not have been possible. They are also heroes. When we talk about heroes, I want all of us to think of our staff as well. Now, with your permission, I will move directly to the recommended actions and issues in the analysis. Thank you. The DLS analysis contains 3 recommended actions. The department concurs with the recommendations. Turning now to the 5 issues for discussion. In response to issue 1, regarding the reason for the decline in timely reporting and steps were taken to resume fiscal 2021 reporting timelines, the department agrees with the importance of returning to pre-fiscal 2021 reporting timelines, of ensuring youth in foster care receive timely education, physical, and mental health services. The pandemic limited the availability of in-person visits and scheduling with healthcare providers within the mandated timeframes. It was also difficult to ensure children and youth who receive or were in need of individual education plan receive service timely. The department is taking actions so that we return to pre-fiscal 2021 reporting levels. We have a new child welfare medical director who joined in January this year, who will focus in that as well. We have established a new SSA audit and compliance quality implementation unit. We constantly reiterate to caseworkers the importance of maintaining up-to-date medical, educational, and physical services to children in our care. Additionally, the department will continue to enhance CGM's reports and the ability to share information within MDH and MSDE. In response to issue 2, commenting on efforts to prioritize the well-being of social workers during the pandemic, first I want to say that prioritizing the well-being of social workers during the pandemic and at all times is critical to maintaining staff morale, and it is the right thing to do. Support begins with building communications between supervisors and subordinates. To ensure the flow of communication, we have made the commitment that all staff have the necessary tools to succeed. This has included distributing laptops, computers, iPads, and cellular telephones to staff and supervisors. Providing staff training developed by the department's learning office, which focus on helping supervisory staff understand their role as a coach and mentor. We have partnered with the Maryland Institute for Emergency Medical Services System to provide peer support for mental health. Staff also have access to MyMD Cares program, which provides state employees access to counselors on call 24 hours a day, 7 days a week. In addition, many local departments of social services have developed quiet spaces within their offices to allow workers time to decompress and process the stresses of the job. The expansion of telework, which I spoke the last time, also allowed many workers greater flexibility. They were able to adjust their schedules and work more efficiently. The department continues to explore additional options to provide support. This is going to be an ongoing effort. In response to issue 3, regarding the impact that the changes to the requirement for FIA entry-level positions are expected to have on service provision and supervisor needs, the department took a number of actions to increase the worker efficiency, which minimize the impact of vacancies on FIA clients. To increase hiring, the department is expanding entry-level opportunities. The department does not anticipate any negative impact on service provisions or supervisor requirements due to this change. In response to issue 4, regarding the HHS recruitment plan and the impact on department-wide vacancy rates on service delivery, the department concurs with the analyst's recommendation. We will provide a report on a recruitment plan and the impact on department-wide vacancy rates on service delivery. In response to issue 5, regarding data reporting for the E&E and CGM's applications, the department takes data reporting very seriously. The data reporting issues are common with any major IT transition and do not reflect a problem with the underlying technology or system. As issues are identified, they're being addressed and resolved, and we're working hard to have them addressed this fiscal year. This concludes my testimony and response, and I will be happy to address any questions the committee may have. Thank you so much.
Thank you, Madam Secretary. Are there questions from the subcommittee? Okay, I have a few. Just kind of wanted to start first with the conversation about the well-being of the staff and, staff morale. I know that a big part of our conversation during your overview, and I mentioned I'd be bringing this up probably again, is the issue of the vacancies, particularly in this area. And I appreciate in your response, I did see in your response, it looks like you have a multifaceted approach to helping with self-care and taking care of the well-being of the employees there. Have you done any kind of sort of in-reach surveys, evaluations to ask the staff what they might find helpful in terms of dealing with morale issues? Because it sounds like two things. One is the pressures of doing social work. As a former practicing social worker, I understand just the pressures of the work can impact recruitment and retention. But also just wanting to hear about the morale relationships with supervisors, because it seems like you've noted that as well.
Thank you, Chairman. It's a very good question. We have done a number of surveys, but I'm going to ask my HR director, Dan Wade, to come up and elaborate on what has been done to that end. Mr.
Very
Wade?
good.
Thank you so much, Chairman Griffith and members of the committee, for letting us talk to you about this very important issue to us. My name's Dan Waite. I am the Director of HR at the Maryland Department of Human Services. The department does, as the Secretary said, take very seriously the idea of ensuring that all staff have an experience that enhances their morale and gives them interest in long-term careers with the department. We have surveyed staff on a semi-regular basis. We probably could do a better job with it going forward. And we have heard from staff in various forums the needs that they have in order to help them overcome the stresses of what is truly a stressful profession. Additionally, we just actually implemented an exit interview strategy that will give us a central pool of data to review and to learn from, and hopefully to decrease the number of exit interviews that we engage in.
Okay, that's a good start. So I'll look forward to hearing more about the kind of frequency with which you understand you follow my direction there. So we'll continue to talk about that. And I wanted to, as kind of a follow-up, talk about something Ms. Pedersen pointed out on page 17 of her analysis that was referring to the changing in your credentialing requirements as an effort to fill some of the vacancies. And I guess my question there first, I'm assuming that we're carefully making sure that folks are trained to do the work since the credentialing requirements are being reduced, but also was curious as to whether or not this is a local issue or if this is something being experienced nationally in like programs. Is this a Maryland problem or is this a national issue? And the solution of reducing the credentials for the staff coming in, is that a response that's being utilized in other parts of the country?
I'm going to start, and then I'm going to have Mr. Wade elaborate more. But as I do know that staffing shortage is a national issue. Mm-hmm. And I do know that we're in a new staffing paradigm that really requires new solutions. We need to get creative and look at what resources we have available to address the staffing shortage. And also look at experiences and lessons learned and compare that with our mission to help the people that we serve also be self-sufficiency and have work opportunities available to them. And that's somewhat of the thinking that I and the department had when we explore the opportunity to revise the educational requirements. I'm going to stop here and let Mr. Wade elaborate more because he has done a lot of work in that area, and we want to give you as much information as we have today for you.
Sure.
Again, thank you, Chairman Griffith. As the Secretary said, we are aware that the post-pandemic era and the challenges that were associated with the unique circumstances of the pandemic have created a new labor market paradigm. And as we look at that new landscape, we want to make sure that we're doing a number of things. That first of all, we are filling our vacancies. That second of all, we are maintaining the quality of service to our customers and constituents. And third, as talked about before, that we're maintaining a work environment in which people can have long and fulfilling careers. As we looked at this issue and the FI Specialist Series is an entry-level series within the department, we started talking about what does it really take to do that job. And we did look at some surrounding jurisdictions that did not have the bachelor's degree requirement that we previously, or that we currently have, but we are moving to change. And we looked at experience within the department and our FI-AIDS program, which is a public assistance to work program that involves a number of people doing this work already who do not have bachelor's degrees. And we realized that those folks have been extraordinarily successful in doing this work, that those folks have had longer careers with the department, and that as long as we are continuing to work to develop those individuals, there is a vast pool of potential out there that is not currently being tapped. We realize, consistent with our mission, that the bachelor's degree requirement can be a barrier to entry for the very people that we serve. So we want to make sure that as we move forward, we build that opportunity and get that deeper pool of folks who we know can be successful doing this work.
Okay, so in that area, and I won't belabor this, we can certainly talk offline, but so I'm looking at Exhibit 7 on page 15. So I'm assuming you're referring to like the Family Investment Specialist 1, 2?
Yep. Specifically, we are making changes to all of the specification in the Family Investment Specialist series. The biggest change is in the Family Investment Specialist 1. As you move through the series, we are continuing to have certain educational requirements as you move into lead and supervisory positions, because we did want to make sure we continued to incentivize continued education in these groups.
I appreciate that and appreciate your response. Everyone is trying to be creative in filling vacancies so that you can have a positive impact on the caseloads, which can impact morale. So it's all interrelated, but I certainly want to stay tuned with you to make sure that we're mindful of changes and that potential impact on morale as well. So thank you for your responses. Senator Rosapap.
Thank you. I wanted to follow up on this question, which is obviously a big one. So in the chart on page 15, currently or until 3 weeks ago or a year ago, whatever, what were the education requirements for each of the categories here? Family investment, social services, child support, and what's called used in multiple administrations. Are they identical? Are they different?
I do want to start by saying that the proposed changes are only in the family investment. We're not proposing any changes in any of the other categories.
I know.
Mr. Wade, you want to elaborate on the educational requirements?
Yes.
I just don't know what they are.
Thank you for giving us a chance to respond to this question. The educational requirements were different depending on the type of work being done. In the Family Investment Series, there was a requirement, or continues to be a requirement, for a bachelor's degree, but there are certain substitutions for experience. In child support, the entry-level child support position, child support specialist trainee, the education requirement was an associate's degree. And for the social services positions, there are a number of sort of different educational requirements there depending on the classification. In the social work series, that requires specifically a master's degree and licensure from the Board of Social Work from the state. We also have our family services caseworker positions, which require a bachelor's degree in a human services field. And the casework specialist position is an interesting sort of hybrid in that it requires a master's degree in social work, but is really a holding point so that folks who have the master's degree in social work but who have not gotten their license yet can come in and work for the department doing case carrying work.
Okay, and then the used in multiple administrations, that list below?
Yeah. Yes, sir. Those positions are sort of, again, a myriad of different
They vary.
Excuse me, sir?
They vary?
Yes, they vary.
Okay, I understand. And so you mentioned a BA in a relevant field. In the BA requirement under family investment, is that BA in a relevant field or just any BA?
It was any bachelor's degree.
Gotcha. And these degree requirements, where do they come from? I mean, is this just something the department has established over the years, or is it somehow related to licensure, or is it somehow related to some third party telling you what you got to do?
So the requirements for the job spec are developed for the positions that are unique to the department as a partnership between the department and the Department of Budget and Management. For the social workers and specifically, though, that is a statutory requirement. The level of education and the licensure is a statutory requirement.
Okay, but the BA for the family investment folks, that's what, just to be sure, that one is without regard to major or field.
Correct, and one of the things that we hit on as we were talking about this is the idea that there is no college that trains somebody how to do that specific work. We are the place where people learn how to do that work.
Thank you, Madam Chair.
Thank you. Are there any additional questions from the subcommittee? Okay, seeing none, thank you very much, Madam Secretary, and those of you that have joined. I don't have any further questions, and no witnesses are signed up on this budget, so we'll see you next time.
Thank you.
That
Look
concludes
forward.
the hearing on that budget. And colleagues, we're going to turn to MDH Prevention and Health Promotion Administration, and our analyst will be Ann Wagner. We'll give her a moment to get adjusted and get started as soon as she's ready. And good afternoon.
Good afternoon. Nice to see you in person.
Yes. Okay.
All right. Thank you very much, Madam Chair, members of the committee. It looks like I got it to share on the screens pretty well, so I'll try my best with that. So today, I'll be presenting the budget analysis for the Prevention and Health Promotion Administration under the Department of Health, or FIPA. So FIPA's budget decreases by about $500 million, largely in federal funds related to the COVID-19 pandemic. However, when you exclude COVID-related funds, the allowance actually increases by about $18.2 million in total funds. And this is driven by $12.3 million in additional general fund spending. So I'll jump ahead to the performance analysis section of the analysis. It starts on page 4. This first item relates to the state's recent efforts to prevent and manage diabetes. Under the total cost of care model, Maryland chooses certain population health domains for the state's entire healthcare system to prioritize, and one of these approved domains is diabetes prevalence. So this first exhibit on the top of page 5, it looks like, this shows that overall Maryland is ranked kind of in the middle compared to other states, with diabetes prevalence recently improving. And I should say that this data comes from a preliminary analysis of how the state's been doing with the total cost of care model. This kind of sets a baseline, because as you can see, the 2019 measure wouldn't have, or the total cost of care model hadn't started yet, but this kind of serves as a baseline over the years. And so you can see that Maryland is generally in the middle. They showed a slight improvement with diabetes prevalence, no change over the period shown for obesity prevalence, and then a worse outcome for body mass index. And so then to coordinate the healthcare system's efforts on reducing diabetes prevalence, the Department of Health published a state diabetes action plan. Under this plan, the department set certain goals, and you can see those listed on page 5. And I will say that the department has set up a dashboard to present some of this data as part of the action plan, but when this analysis was drafted, the dashboard was still down due to the ransomware attack. And so the department is asked to comment on when the dashboard will be brought online again. Exhibit 3 presents some of the measures that were available outside of the dashboard, so those are included for your reference. You can see that over the period, diabetes and obesity prevalence both grew worse since 2011, although most recently, diabetes prevalence has fallen slightly. And so this increased focus on diabetes overall has led to multiple new programs and efforts to respond to this, manage this condition in the state. Some of the department's efforts are shown in the middle of page 7. I won't go through those too in depth here. But then another large, kind of large infusion of support for diabetes programs comes from the HSCRC's Regional Partnership Catalyst Grant Program. These grants mainly support diabetes prevention programs, which are year-long lifestyle change programs, and diabetic self-management training sites. And so, lower on that page, you can see how this funding over 5 years is split up among different hospitals and different partnerships with hospitals. And those hospitals also go on to partner with community-based groups and other groups as well. But there is some new funding specifically targeted to diabetes programs. And so then I'll move on to the next performance analysis item, which has to do with contact tracing during the COVID-19 pandemic. Exhibit 4 on page 9 shows that the department reported contact tracers generally reached over 75% of people recorded with a positive COVID case in most weeks since June 2020. In late December, however, as the COVID-19 positivity rate jumped during the surge related to the Omicron variant. You can see that with the green line at the bottom there. You can see that contact tracers then only reached about half of positive cases. So there was a drop in how many people they were reaching at that time. And so although the department has published these measures consistently, you can see since June 2020, it's not clear whether there are any specific benchmarks or goals that were set for the state's contact tracing efforts. And then also there have been a portion of federal aid for the pandemic that's been spent on expanding contact tracing infrastructure. And so since this tool is used in public health for other conditions, there could be future use for this infrastructure and for the support that's been provided to contact tracing for other conditions. So the department is generally asked to discuss whether contact tracing has been effective in limiting the spread of COVID-19, if the department has set any specific goals for measuring success in these measures, and then how new contact tracing infrastructure might be transitioned for more ongoing uses. So then moving on to the budget discussion. In fiscal 22, the Prevention and Health Promotion Administration's budget has grown significantly due to CDC grant funding for the state's pandemic response. Exhibit 5 shows broad categories for how this funding has been used in fiscal 22. You can see that data systems, IT, and teleworking expenses made up the largest percentage or the largest share of this funding. And then the next largest share of funding came through the American Rescue Plan Act as a grant that was specifically meant to help schools stay open or reopen. And so that's shown in the yellow wedge on this chart. That funding could be used for things like testing and cleaning supplies and personal protective equipment. Other major public health efforts were also supported with these CDC grants, such as testing and contact tracing and vaccine distribution. But I'll note that it isn't as large of a share of this specific funding as there was also other federal aid that could be used on those activities. So there was FEMA reimbursement, coronavirus relief fund. There's been a lot of other funding available for those purposes as well. Moving on to Exhibit 6. This shows how the fiscal 23 allowance compares to the fiscal 22 budget in COVID federal fund spending. You can see that fiscal 22 has significantly more budgeted as the pandemic response has continued in this year, and then in fiscal 23 it's not expected to need quite that level of federal aid being spent. I will note, though, that over the past 2 years, a lot of COVID-related funding has been added through budget amendments outside of session and then through supplemental budgets added later in session. So it is possible that there could be some amount of additional federal funds available. And the department is asked to provide an update on how much funding still needs to be added to the budget and a timeline for adding those funds. The department is also asked to discuss whether the fiscal '22 budget is sufficient to cover the recent surges or surge related to the Omicron variant, and then how ongoing public health costs like maintenance for new data systems will be covered once the one-time federal aid ends. Moving on to the fiscal '23 allowance, jumping ahead to page 17, I'll just highlight just a few items in the allowance. So the first I'll highlight is that there's $9.6 million in additional general funds. This is added to meet a minimum funding level for tobacco and prevention and cessation activities. The digital advertising bill from last year set a mandate for tobacco prevention and cessation activities to receive $18.25 million, and so that's what this additional general funds are supporting. And so this funding supports local tobacco control programs, media contracts, and grants to some community-based groups. There's also funding in this budget for maternal and child health uses. I'll just jump ahead to looks like the bottom of page 18. There was a bill in the 2021 session passed that increases the mandated level for the prenatal and infant care grant program. The mandated level for fiscal '23, I believe, is $1.1 million, and the budget includes $1 million for this fund, so it's just slightly under that mandated funding level. Then moving on to the personnel discussion. FIPA continues to report more vacancies than their budgeted turnover. So the department is asked to comment on how it will fill about 24.5 vacancies to meet that budgeted turnover. And then the department should also discuss how it has been tracking regular and contractual personnel that have been funded with the federal aid related to the pandemic. You can see from this chart that the budget reflects 16.2 a net increase of 16.2 contractual positions. And so there is a question posed to the department just to clarify how positions supported with COVID federal funding have been shown in the budget. There are three issues I'll go over briefly in this analysis. The first one has to do with school-based health centers, specifically the transition of school-based health centers or grant administration from the Maryland State Department of Education to the Maternal and Child Health Bureau under FIPA. That was required in was also required in 2021 legislation. The fiscal '23 allowance reflects this transition, with the budget showing $9.1 million in total funds for this program. This includes $6.5 million in special funds from the Blueprint for Maryland's Future Fund. The Blueprint bill increases funding for expanding or maintaining school-based health centers. And so the budget does include that funding in $6.5 million in special funds. I will note, too, that MSD didn't have any dedicated staff supporting these grants, and so MDH doesn't gain any positions to take on these responsibilities, but it currently plans to administer the program with existing positions. Exhibit 9 presents kind of a detailed timeline of how the transition has been going, but I won't go into that, go through line by line on this timeline, but the department still has some activities left in fiscal '22, and the full transition will be implemented at the start of fiscal '23. So considering the additional Blueprint funding that was allocated to this program, the department is asked to discuss how many new centers would be added per year, or how that funding would be used otherwise. And then if the department has any strategies to recruit healthcare providers and partnering agencies to set up new school-based health centers. And then if the department plans to implement any recommendations that have been outlined by the council on advancement of school-based health centers. Moving on to the second issue in this analysis. This relates to the state's, to the Maryland AIDS Drug Assistance Program. Under this program, the state receives rebates on any pharmaceuticals purchased above a certain price that's set by the federal government. These rebates are often used for the services that are listed on page 22, like healthcare, housing supports, and preventative services for people with HIV or AIDS. In the past few years, FIPA has maintained a large fund balance of these rebates, with a balance of just under $60 million reported at the close of fiscal '21. Most recently, these rebates were underspent due to the pandemic causing programs to have to close temporarily, and then also because services were limited as personnel and other resources were diverted to the pandemic response. At the same time, the department has just recently upgraded its MADAP program case management system to become a major IT project, and it's currently set so that the out years would be funded with general funds. I will note that the fiscal '23 allowance does budget a little over $2 million for that major IT project. So it's not clear why special funds or rebate funds aren't planned for the out years, and the department is asked to discuss the budget for that program moving forward. There is also, let's see, this program has also been affected by the ransomware attack. Currently, MADAP employees can't access their client database, and so this has meant that the department has to use workarounds for eligibility determinations for existing clients, and new clients have not been able to enroll in the program. And so the department is asked to provide an update on this information system, including whether any long-term solutions have been put into effect, and then how many existing and new clients have been impacted by the eligibility determination issues. And then finally, how the department would provide outreach to any new clients who've been unable to enroll during this time. Finally, the last issue has to do with the WIC program. This provides food assistance and nutrition education to low-income women, infants, and then children up to age 5. Exhibit 10 reflects recent enrollment in the program by the eligibility categories. This exhibit shows that total enrollment has steadily declined in each of the past 5 years, but the rate of decline has slowed recently, and the decline in enrollment is seen nationally. This is in line with national trends in WIC enrollment as well. In fiscal '21, you actually are seeing enrollment among children increase slightly, but this was offset by the drop in women served and infants served, shown here. The other note in this issue is that the fiscal '22 budget includes $9.7 million in enhanced WIC funding, and that was authorized in the American Rescue Plan Act to increase the cash value voucher to $35 per child and adults for fruit and vegetables. That was only a temporary enhancement for 4 months. So MDH had this in effect from June 21 to September 2021. The department is asked to discuss the factors causing enrollment among children to increase and whether the increased benefit through that the rescue plan has increased enrollment so far. The department should also provide an update on any new efforts to reach more people who are eligible for WIC and might not be receiving benefits currently. And then that concludes that issue. In terms of recommended actions, DLS recommends concurring with the allowance. And with that, I'll conclude the presentation. I'm happy to answer any questions.
Thank you very much for your analysis. Are there any questions for the analyst? Okay, seeing none. I'm sorry, Senator Eckert?
That's all right. Thank you very much, and thank you, Ann, for your presentation. I had 2 questions. The outcomes for diabetes, and then because we put a lot of effort into making improvements, but it didn't look like we were getting much improvement. So I guess, do we have any other information that might shed light on what might be going on there? Because we were looking at, I think, 2013 data and then 2018 data. But for the investment around the state, I'm just curious, what do we really expect? And if we're not getting what we were expecting, how do we think about that? That's
Right.
one question. And then the other one, a similar question with the tobacco prevention and cessation activities. Again, we put a lot of funding into these efforts, and did you come across any data that would indicate progress or goals, and what are we getting for our investment of funds, other than we're doing a lot of things?
Sure.
Did you come across any of that?
Right, so I'll start with the diabetes metrics.
Sure.
I will note, I think that's kind of a data lag issue. It is 2019 is kind of when total cost of care model is starting. So I think over time, we'll start seeing the impacts of these investments. I think the department should be able to respond in terms of specific benchmarks and goals they're trying to hit with those metrics. But in terms of kind of what you're seeing now, I think that the 2019 measures serve as a baseline, and then over time, the department will have to show improvement over other states, other metrics, and show over time moving forward that they've improved since 2019. So I think it kind of serves more as a baseline, and I think that kind of suggests why diabetes prevention was chosen as a focus, was because of these metrics being relative, middle of the pack kind of among states. So in terms of diabetes prevalence, I think it is kind of a day lag issue, but I'd be happy to look more into that and see if there's any more recent data available and if there's certain targets that the state's trying to hit. And then in terms of tobacco prevention, I didn't include the data here, but generally over the past couple of years, I believe traditional tobacco use has been in decline. It's been going down. There was a time where e-cigarettes were growing very popular, and I think there has been a shift towards putting those resources towards e-cigarettes, or at least including those in the prevention and cessation. But at least in terms of the state's use of traditional tobacco, it has been going down over time. But again, I think the department would be better equipped to say whether there's specific targets that they set on that.
Great, thank you very much. Thank you, Madam Chair.
Thank you. Senator Young.
Just a couple real quick things. The diabetes is all related to type 2 diabetes, is it not?
I think that's the focus, yes.
Okay. And the cigarettes and the expenditures there too. Has anybody ever looked as to whether the money we're spending is having an effect, or if it principally comes because of the fact that we've increased the taxes and people give it up because of the cost? Is there been a look at why it's going down? If we're really accomplishing something here, or it's because of the money?
Right. I mean, this has been a use of like the cigarette restitution fund for a long time, and there have been annual reports. I think if I remember correctly, the annual cigarette restitution fund reports kind of report more on like what the programs have done. I don't know if they necessarily tie the prevalence of tobacco directly to the programs, and they can say, oh, this many people, I don't know if it's tied that directly, but I think that would be something that I can follow up and see if there are any reports that look into that, and I'm sure the department could also respond to see if they have any that comes to their mind.
One other thing. The department is having trouble finding employees. Is that a common thread?
Yeah, I think at least in this budget, yes, that has been talked about in a couple different analyses.
While we've been having trouble, it seems like we've hired contract employees. I'm sure that's probably to access certain funds, but are those employees qualified to fill the vacancies we have as the funds go away and they're not needed anymore? I mean, while we can't find employees, we're finding them for contract jobs.
Right. I'm not sure I'm equipped to answer that question, but I mean, you are seeing, at least in this budget, contractual full-time equivalents are going up 16 positions. So yes, there is more, I would say more use of contractual positions. And so, yeah, that would be a good question for the department to see how they're transitioning those positions to regular, if they are doing that.
Okay, thanks.
Thank you. Any additional questions? I just have one, and it may be better directed to the secretary and his team. I'm really, really pleased to see the partnership grants that are going to the teams that you mentioned on page 8 of your analysis. Are we scheduled, do we get any reporting from them to let us know how those projects are going, or whether they're collecting any data for measurable outcomes on those projects?
I believe that would be under HSCRC, and I can definitely look for those reports and share them with the committee.
Yeah, it looks like there's some great partnerships with some great objectives, but would love to see how they're doing. And it looks like we have a couple more years to go, but want to make sure they're being effective along the way.
yeah, I will look into that and see if I can send you any reports that the HSCRC might have put out.
Thank
On
you
those
so
grants.
much. I see no additional questions for the analysts, so we will invite up Secretary Schrader, the Honorable Dennis Schrader, and whoever you'd like to bring up. Good afternoon, sir.
Yes. Thank you, Madam Chair. I will ask, I'm joined by Dr. Jinlene Chan, Deputy Secretary for Public Health, and she'll be giving a brief summary of our written response. We also have additional folks here to ask questions. We have our CFO, Emily Brandenburg, our Budget Director, Nick Napolitano, our PHS Budget Analyst, David Davis, Donald Google, who's Director of PIFA, and Webster Yee. So I'm confident we'll be able to answer most questions. So, Madam Chair and members of the subcommittee, for the record, my name is Dennis Schrader. I'm the Health Secretary. We thank the Governor and the Budget Committee's support for our COVID-19 response effort to date, and we thank the Department of Legislative Services budget analysis and its recommendation to concur with the Governor's allowance. One note I wanted to make, and Dr. Chan will elaborate on this, about school-based health centers. We are actually very excited about this program. We've been working on this for a few months now, getting ready for the July 1st turnover. I've assigned Deputy Secretary Steve Hsu, who's our Healthcare Finance and Medicaid Director, and Dr. Shelley Chu from Public Health is leading the task force. We intend to go far beyond the current grant-funded mission to leverage Medicaid with this opportunity. We see it as a major opportunity to leverage Medicaid for these centers as a population health force multiplier. 50.6% of our Medicaid Health Choice members are under the age of 20. And so we, there's about 1.4 million Medicaid members, and that varies a little bit because of the COVID public health emergency. We're not allowed to allow people to be removed from the rolls, and that will change. But 1.4 million has been the general average, and 745,000 of them are 20 and under. So we believe that school-based health centers can be leveraged to assist in the access to care delivery, and we've been putting those plans in place and are very pleased about the opportunity to do that. I think the legislature was very wise to move that program last year, and we're going to take advantage of it to make it very successful. And Dr. Chan will talk more about that. The only other thing I'll mention in response to your question, Senator, about the contract positions, we are using those contract positions for the recovery and response operation for COVID. People come and go. Like for example, when we had mass vax last year, those numbers were up, then they come down. We're in the recovery phase now, but we're using contract positions for that because people come and go and the demand is up and down. So we can provide more detail about that, but that's generally what's been going on and why you're seeing that increase in contract positions. So I'll turn it over now to Dr. Chan for a brief summary of the written response.
Great. Thank you, Mr. Secretary. Thank you, Madam Chair, members of the committee. I'm so pleased to be here with you today to discuss the budget for the Prevention and Health Promotion Administration. Again, for the record, my name is Dr. Jinlene Chan. I'm the Deputy Secretary for Public Health Services with the Maryland Department of Health. I would like to again thank Ms. Wagner for her detailed analysis and really in-depth assessment of the budget, and also appreciate her recommendation to support the budget for FIPA, as we call it, PHPA. This administration, PHPA administration, has huge responsibilities to address the key pillars of public health, including maternal and child health, environmental health, infectious diseases, surveillance and prevention, as well as cancer and chronic disease prevention and management. I would like to take a moment to recognize and thank the staff in the FIPA administration for their tireless work to protect people's health across the state. Whether it is to investigate foodborne illness, ensure safe drinking water, preventing cancer, or protecting infant health, the tremendous public health professionals at the Maryland Department of Health, as well as in local health departments that do the work at the ground level in communities across the state, have continued to ensure access to these critical public health services and resources, even in the face of also responding to the ongoing COVID-19 pandemic. Some of our highest priority population health goals we have already talked about and has been mentioned, but it bears emphasizing because it really is a unified effort across the state, and it really takes all of us to really focus in on such huge goals that we have for our state's health. So with the State Integrated Health Improvement Strategy, or the SIHIS program, we continue to move forward with the leadership of individuals such as Dr. Chu and others within the FIPA administration, including this coordination to reduce maternal morbidity, reduce pediatric emergency visits due to asthma, prevent diabetes, and to prevent opioid overdose. I'd like to turn to addressing some of the specific questions that was mentioned in the budget analyst's remarks and in her very detailed report. So first, with diabetes, we do plan to update the existing data as soon as possible, and while we don't have a specific date, we do anticipate that the dashboard will be available later this spring, 2022. The latest 2019 metrics related to the goals that were outlined in the state's diabetes plan are included in our written response, but as was noted just a little bit ago, that those data points actually predate or right at the start of our efforts related to the total cost of care. In terms of the specific benchmarks, we actually have a number of items that are tied to our goal to reduce the burden of diabetes across the state. And it's actually tied to how it's changed relative to how other states have changed. I will note that not only in diabetes, but in other health metrics as well, the COVID-19 pandemic has had other repercussions, and so we are anticipating some of those and looking ahead to see what we can do to mitigate the outcomes, the ancillary outcomes of the COVID-19 pandemic. Speaking of that, I wanted to talk briefly about contact tracing. So there have been some recent recommendations that were put forth by a number of national public health associations, and consistent with the CDC's recent guidance, we are planning to look at how we can refocus our contact tracing efforts to target the highest risk populations as well as the highest risk settings. That is something that we are actively looking at as we speak. And really the goal is, high-risk populations and settings. We know the elderly, we know about nursing homes and other congregate settings. In terms of use of the contact tracing infrastructure, I think that was also raised in an earlier question. We are absolutely, we invested a lot of time, a lot of effort and federal dollars into really building a very strong system, starting in about March, April of 2020, almost 2 years ago now. And we absolutely intend to look at ways that we will be able to continue to use that infrastructure for contact tracing, because as was mentioned, contact tracing is really the bread and butter of a lot of what we do in public health in terms of infectious disease mitigation and surveillance. So we do need to evaluate that, and it's something that we are talking about right now. In terms of the CDC ALC federal funds and other awards, I would refer you to our written response for some detail there regarding those awards, and we're happy to answer additional questions about that. With the vacancies, I know that this is a question that has come up a number of times in multiple hearings, and, this is something that we have always been actively searching for and recruiting for individuals. To piggyback on the Secretary's comments about contractual individuals who are specifically working right now in our COVID response, as our response continues to evolve, we are absolutely looking at ways that, where appropriate and where it has a good fit, where we may transition certain staff with the appropriate skill sets into more permanent positions. I'd like to turn to the school-based health center program, and, really, I think the Secretary outlined that we're taking this opportunity with at the suggestion of the legislature, and appreciate their leadership on this, to really reimagine school-based health centers and what its role can be, and also in the context of the total cost of care and the SIHIS program as well, where our goal is to really have everybody on board, rowing in the same direction towards the same goals, and school-based health centers are absolutely no exception, and we think that they will be a tremendous avenue for us to engage more individuals. So right now, we are focused on transitioning this program from MSDE to MDH by July 1. They, of course, will still be involved, and so we've been working very closely with them. To implement this transition, MDH will be conducting, and we're in the process now, a statewide needs assessment to actually better inform the implementation of these school-based health programs in terms of the strategic priorities, how we might grow it strategically, looking at areas of disparity and need in particular, as well as structural development and what the needs are. I think that we want to use the grant dollars very carefully and strategically so that we apply it to where the need is, and so that we have a strategy going forward. So that's really our first order of business, and that's one of the recommendations that came out of the council that we're absolutely taking to heart and moving forward on. This is, as I said, to identify our priority areas for new school-based health centers, as well as to help inform what we hope would be a sustainability model for those health centers going forward. We do intend to expand access to those services. That is something that's critical, which includes not only increasing the utilization of existing ones, because we want to take a look at what's existing and build on it, but also where there maybe there are no school-based health centers in some jurisdictions, and there's a number of schools that, of course, do not have school-based health centers, but that's where I think our needs assessment will help inform that. We do appreciate the recommendations provided by the council on advancement of school-based health centers, or CASBAC, and we do look forward to continued conversations with them to implement some of the recommendations that they have put forth. I'd like to turn to MADAP. I know that's a big question. Just wanted to comment that over the last 2 years of the pandemic, we have actually seen service utilization and fund utilization drop quite a bit because of changes in services. There was, for example, an eviction moratorium, and so some of the funds used to be able to pay for rent, for example, but we anticipate with changes, ongoing changes at the federal and also here changes at the service provider level, that as we move back into more pre-pandemic service utilization, that those dollars will be used. In terms of the program access, since the network outage that started in early December, our program has been working tirelessly to implement manual workaround procedures to maintain coverage and access needed to medication and services. At this time, we are able to provide services to recipients, including, enrollment if needed, paying for claims, access to medications, and pharmacies. We are aware of 22 new individuals who have been impacted, and we have made sure, when we have learned of them, that they were connected to appropriate resources. So since the network outage, the program has been continuing to make sure that people do not have a lapse in coverage. We would ask that people contact us at the program site. It's all the information's available on our MADAP website at the Maryland Department of Health to contact our program if they have any questions about their coverage. And then lastly, I want to just touch briefly on the WIC program. Of course, this is one program that's very critical as we talk about maternal and child health and the importance of ensuring that we address the disparities and improve maternal morbidity related to SIHIS. And so early in the COVID-19 pandemic, Maryland, along with other states, did get an approval to implement a waiver for what's usually a strict requirement for physical presence to allow families to actually access the services remotely or by phone. And so this has actually allowed for much increased enrollment of families and allowed for families to continue to be retained and to receive services, importantly. We are and have convened a stakeholder work group to discuss updated data and to get feedback, and we hope to be able to share that data with Medicaid and look at ways that we can interconnect our systems better, whether it's through Medicaid, MCOs, and others, to ensure that appropriate referrals are made. So with that, Madam Chair, I am happy to take any questions, and we're all available here. Thank you.
Thank you very much for that presentation. Senator Roosevelt.
Thank you, Madam Chair. I have quite a few questions. I'm happy to take a breath when Senator Eckert wants to ask a question.
Okay, we'll go 3 to 5 and then catch up. No, I'm
There
just
you
kidding.
go.
Go ahead.
No, I understand.
You can proceed.
I want to start with the school-based health centers, and I generally know about it, I don't know that much about it, and I apologize. The chair knows this, I didn't realize we were having this hearing today, and so I hadn't read the stuff ahead of time, so I'm a little behind the curve here. On the school-based health centers, my impression is there are a bunch of them around the state, but obviously not in most schools, that there's been, what is the traditional funding for the school-based health
Yeah,
centers? Actually, I don't know.
I'll take the big picture and then Dr. Chan can add. The way this was operated, and it was that historically, the Department of Education had a $3 million grant program. And they would distribute the grants. That did not yield the desired result by the legislature.
Right.
And so there was a recognition that really we're talking about providing health services in the community.
Yep.
And so we were approaching it in that way.
Got it.
The grant program is very small.
Right.
But it's just the foundation. We have a huge Medicaid budget, and this gives us for me, I view it as another venue to get access.
I'm with you. No, I get the big picture.
Yeah,
So the reason we have so little is because we were investing $3 million a year.
yeah,
Okay,
it was
I
a
got
very
it.
small program.
So I have the general sense that you can use Medicaid money for this because you're providing medical services to low-income people. That's the big idea, right?
Yes.
So why haven't we been doing that forever?
Well, because the reality is when the program was obviously the school systems have a major say in how this is done. And the school systems tend to be overwhelmed with just trying to educate children.
But nobody ever thought of it before?
I'm sorry?
Nobody ever thought of it before?
I'll turn it over to
Yeah.
Dr. Chan because
Right,
she may
I
have
think
some.
that there's probably some technical aspects to it that we're happy to get into and bring in Medicaid to the conversation. So
Yeah,
they have
yeah,
been
yeah.
part of the conversation for some time. I think some of it is related to the fact that school-based health centers, in terms of their scope, may not be full service that you might expect from, say,
Sure, I get
your
that.
primary care, because they're only open either during the school hours or maybe
Yeah.
a little bit after. So In some ways, the ability to bill, and Medicaid can expand on this for us perhaps at a later time, in terms of being designated their primary care office, and, so there's some billing that's tied to that. But that's absolutely what we're looking forward to doing is,
Great.
Taking it to that next step and that next level. And that's why Secretary Schrader has really directed Deputy Secretary
I got it.
Shu to be very closely involved with this.
And so, but your expectation is the rules, the federal rules, the state rules or whatever, basically allow you to do this, and it's a question of working through the mechanics?
I think
That-
so.
that-
That's
yes.
what we believe.
That's what we believe. It takes, I will mention, right now, there's 90 of them in
Yeah.
the state. So it's not a small thing. I mean, the local jurisdictions, but it could be much more.
Yeah, of course. No, I think it's terrific. I just wanted to kind of, and so you take it over at the beginning of July,
Yes.
and then you're going to do this stuff over the next year or two or three, is kind of the way
Yes.
it works? Gotcha. Okay, thank you on that. I'll take a breath on this one and see if the chair and other people
That
want
was
to ask
pretty
anything.
easy. Okay. Any other questions from the subcommittee? Senator Eckert.
Just make a comment, Dorchester, I think, was one of the very first school-based health clinics years ago, and we have spent probably more than 20 years trying to sort out the funding and how to, it's just been fraught with a lot of issues through the years. So I think this whole change will be very positive.
That's great.
Particularly as we look at the blueprint funding, a number of us have introduced a bill, just a nurse in every school, to continue the conversation, to point out that this is a perfect place to deliver health services. But think about it. If you have families who have their primary somewhere else, but it's convenient to see the kids here, then you get into a little bit of that kind of
Gotcha.
tit for tat. So I'm really pleased with what you put together to make this a reality in more schools.
I agree.
Because it can answer many of our dilemmas we've even been talking about here today. Thank you very much.
Yeah, thank you, Senator. I remember you and I in the House talking about this years ago and the partnership with health centers and our local jurisdictions. This has taken on many forms and iterations over the years, but clearly you all have a handle on the new direction. And perhaps technology can assist with it a little bit too, because the issue of records and
Yeah.
all of that, was a part of the issue back in the day.
exactly.
So, yes, Senator, you can proceed.
Thank you. Tracing. So, big picture on tracing, I hear, is that tracing doesn't work in the middle of a surge because there's so many people to trace, but tracing does work when you're outside the surge. So we are now coming outside the surge. So can you talk a little bit more about sort of our tracing plan over the rest of this year and next year?
As I said in my comments, as the COVID virus, COVID-19 virus continues to evolve, of course.
Yeah.
And so what we've seen more recently with the Delta and the Omicron, of course, is that it's highly more transmissible. And so, and there's still individuals with asymptomatic
Yep.
infection.
Yep,
And so, what we are looking for, as we look ahead, regardless of, changes in the variant or spikes, I mean, we'll always reevaluate. I think that, we've been flexible to date, regardless of what the pandemic and this particular virus has thrown at us. We have continued to flex to try to meet the needs of our population. But what we're looking forward to, and that we're working on now, is a refocusing of contact tracing to where we think it'll make the greatest difference.
No, I
which
heard
is-
that before.
Yeah.
But I'm asking, what are you really going to do? I mean, back a year and a half ago, like the summer of '20, we had a very low success rate in terms of tracing. I remember the hearings we had in the oversight group. And I know you hired this outside contractor to do, is it all the state tracing or most of the state tracing?
They do, it's between local health and.
No, I'm
this-
talking about state. I'm not talking about local. I'm talking about state.
So- But it's a partnership between the state contract and the local staff.
I know that, but for the state piece of it is basically this one contractor?
Correct.
Gotcha. So what I'm trying to get my head around is, we've learned a lot over the last 2 years. Tracing has not been very successful, in my impression, in Maryland. Because initially it wasn't very successful, because people were just scaling up and learning how to do it, and, I mean, the scale was not good. Then we were like, last summer, well, we don't need to worry about all this stuff that much, and so, and then we had Omicron, and so I'm trying to understand strategically what your plan is for this year and next year around tracing.
So, Senator, let me take another
Thank you.
angle on
Thank
this
you.
while Deputy Secretary is thinking about this. I see it as two things. One is, we haven't been just doing contact tracing. There's a wraparound service. The tracing seems to be most effective historically when you have smaller numbers.
Yeah, of course.
And you're trying to, but what we did with the tracing is the consultation with individuals, they get calls, it relieves the stress for people in the community.
I'm with you.
So what I think Secretary Chan and I have talked about is decoupling the wraparound service. We still want to do some of that to help people, but rethink the actual tracing and its usefulness in this process.
Correct. You know, if the goal of contact tracing at the core of its functions, which, you know, again, public health uses, as you well know, is to prevent onward transmission of a disease. So with COVID being, you know, more transmissible and the characteristics continue to change, we will want to refocus it to, you know, that work, that core work, to the individuals who are most vulnerable. And in addition, maintain that wraparound piece that the Secretary alluded to make sure that they have the right information, that they are connected to appropriate treatment and other services.
So you don't have a plan, you're going to have a plan. That's what
We
it
are
sounds
working
like.
on that now as we speak, sir.
You do not.
We are working on that
You're
now
working
as
on,
we
okay,
speak.
I appreciate that. That answers my question. May I continue, Madam Chair?
Sure.
I want to talk about the federal money, because my impression is, I could be wrong, that there is not going to be another big boost in federal money like we saw over the last 2 years. I don't think so. You know, if we need it, hopefully there will be, but help me understand the flow of federal money again going forward. How much do we have in the bank? How much do we get through regular processes with CDC or FEMA or whatever? I mean, if we have a significant surge, you know, 3 months from now, 4 months from now, next winter, whatever, are we on our own fiscally, or where does the federal money fit into the plan?
Let me take a crack at that,
Thank you.
Senator, and then if I can't
That's fine.
get, if there's more details,
Sure,
our
sure.
CFO.
Sure.
We've been working for about 3 months now on what I call a sources and uses plan that imagines what it's going to take between now and January next year. So we're looking at a 1-year horizon.
Okay.
We're also looking at, to your point, how much of each service, because for example, we're going to go to a hot, warm, cold system for the 5 pillars that, you know, testing, vaccination, tracing, and surge beds, et cetera.
Yeah.
So we're building that as we speak while we're on the back end of the surge. And then we're looking at when might the public health emergency end, because that's at the discretion of the federal government. And the real big deal is, what will FEMA's posture be? Because FEMA is really fueling a lot of this, and right now they're at 100%. And we're looking at, okay, if it stays at 100% for a certain period, but maybe it goes down to 75%, how do we cover that gap? Or if it goes to 0, and we're making projections, we've got preliminary models that Emily has put together, Ms. Brandenburg has put together, and we're fine tuning that. So we're going through modeling process, we've gone through a couple iterations, we're gonna continue that, because we wanna make sure that we understand how this is going to be taken care of. And we've been working with DBM, and they've been generous with the governor to give us some backup. So maybe, Emily, if you wanted
Great,
to add
please.
anything to that.
No, I appreciate it. Thank you, Secretary Schrader, and I think he captured most of what I would have said. There's 16 work streams that we study closely, regularly. We look at their monthly spend, we look at what they anticipate might happen, we marry that with their funding source.
Right, I got it.
And then we also watch closely what might happen with FEMA. We model it high, medium, low, different directions, different opportunities, and as this continues to evolve and unfold, we make the appropriate changes, and we relook at the model again to always have a working idea as to what this financial picture may or may not look like, depending on what the federal government does.
Okay, that's the process, but can you give me some sense of the substance? I mean, in your high, medium, and low, your color-coded stuff, what is our financial risk over the next, you're saying just the calendar year, you're not projecting into the next fiscal, or you're not in the next, you're only doing this calendar year, not next calendar
So
year?
we do both.
Okay.
Right, and it's a really difficult question to answer because, again, as the Secretary shared, if FEMA stays at 100% through the end of June, it looks incredibly different than if FEMA stays
No, I
at
get-
75%
No, I get
or
that,
50
but I don't know,
or what have you.
I don't know what 75% looks like. What's the gap? What's the money at risk? That's my question.
Are you looking for like a dollar value?
Yeah.
I don't think we can answer that with any level of certainty, only because we don't know what FEMA and what the,
Well, if you make a
Pandemic will
projection
continue to
of what you think the cost will be, and you assume 100% is one number and 75% is another number,
If-
those are easy.
So we have those models. Could we work with you offline to
Yeah,
share
no,
you
that's
that?
fine. If you send
'Cause,
us the model,
you
I'm
gotta
happy
see-
to
yeah.
look at the model. But
If we could do that,
I don't know
it'd
whether
be
this is a $20 million issue or a $200 million issue
Yeah.
or a $2 billion issue.
We're asking the same question.
That would be great. If you
And
could
we
share
have
that.
some.
If you could
but-
share that with us.
But I don't want to just,
That's fine.
spitball it.
No, that's fine. But I think as the Budget Subcommittee on Health, we actually need to understand what the risk range is on the money related to the federal stuff. So
we'd be glad to.
I
work.
appreciate that.
Yeah.
I got two more, Madam Chair.
Okay, go ahead, and then we'll go to Senator Young.
Oh,
I
so-
see
no, Senator
over-
Young. No, Senator
Okay,
Young.
let
Go ahead.
Senator Young, you can go
Please.
ahead, and then we'll go back to Senator Roosevelt.
Okay, sure, thank you, Madam Chair. I'm probably not as familiar with school-based health centers as I should be, but are they there principally to treat minor things that happen, or do you get on the other side of prevention?
So, thank you, Senator Young, for that question. So, I want to make sure to differentiate between school-based health centers and school health services. Sometimes those can be conflated, and so school health centers or school health programs are intended to make sure that children who have, needs, health needs with, during the school day, that their needs are met. So, whether it's medication administration, whether it's monitoring their blood sugars for diabetes, those are things that school health programs do. School-based health centers, on the other hand, actually, and there's various flavors of them, and they offer different levels of service depending on what they chose to certify themselves for. Can provide varying levels of service that could include, physical exam, more detail. So it really is more of a clinic-based type model, offering different levels of services, and in some cases, even including things like mental health services and the like. So I don't know if that helps kind of
It
paint.
helps some, but neither one gets into things like working with the school on school meals that are healthy, because that's one of the biggest problems, frankly, in the country.
Well, that is a much bigger and broader issue, and, I know that school systems are working across the state on just that exact topic of how to make school meals healthier, how do we, transform that, school meals. And so many children depend on the school meals provided, breakfast and lunch, and sometimes even dinner, that it's really incumbent on us to make sure that they're provided nutritious meals.
The schools claim they're doing a good job on that, but they're not. But back to the health centers and what they're doing, that's great, because I've had to battle 3 or 4 bills through for things in schools for health problems, including one I have right now on epilepsy. And a school-based health center would really have somebody there that doesn't throw it back on the teacher or whatever to help with. I mean, I had to battle a diabetes bill through, an epilepsy bill, and a couple others, so they would be very helpful in those areas, I think.
Yeah, if I might add, you mentioned something, I really see this as part of our prevention mission,
Yeah.
If we can get these children, we want to get more children into physicals, annual screenings, and for many of these children, they don't have pediatricians. So this gives us an opportunity to get them for, counseling and, weight control, if they have other conditions. There is a program, and we're working with the managed care organizations on this because we have to, and that's why Deputy Secretary Shu becomes so important, is because as we set the priorities for the Medicaid program, we can pivot because I know there's been some programs in the city that look at vision care that I think are very valuable, and we need to get Medicaid more engaged because that's a covered service for Medicaid. So my vision for this is not just giving somebody a pill when they have a headache. It's really getting into what you're talking about.
Well, that'd be great if every school could have one, and we could have a school nurse to help run it there, so.
All right, thank you, Senator. Back to Senator Rosapap.
And this does relate to schools, but also to testing. I don't know exactly what the status is of school testing for COVID right now. My impression is it's still pretty ubiquitous. Is that your impression?
So, the program that we provided, this is just for background, just generally, there's a $182 million grant that came through as one of the many ELC grants for K through 12 testing. It came through about March or April of last year. And so we did a procurement to engage vendors that could do testing in the schools, and so provided that to school systems as well as to private schools to be able to offer services for their students. And so there has been variable engagement across the state, and even within a particular county that is working with our vendors, it may not cover every school. And so it really is dependent on the school system and the school in some cases. So, and there's kind of basically two types of screening or testing models that the schools can adopt. One is more of a screening model in which they may test students on some regular basis, usually once a week or once every 2 weeks, or diagnostic testing only with symptoms. So I don't know if that provides you with.
Well, it helps a little bit. But so basically, well, let me ask you this question. I mean, are all the school systems doing some testing regularly, either surveillance or diagnostic?
So I think that all school systems are at least referring if there is a need for diagnostic testing. In some counties that are not partnering or using some of our vendors, they're working with their local health departments. Baltimore City, has also engaged their own vendor for testing in addition to working with us. So, I think there's quite a spectrum. We'd have to provide, if you were interested in the detail, we can provide that to you.
Actually, I would, if there's some kind of summary of that. What got my attention on this was I heard that you all were doing an RFP on testing in the schools. I heard that
Right, in the summertime.
From somebody. I'm sorry?
It was in the summer.
No, I heard recently that you were doing an RFP. Is that wrong? Was that just, I may have bad information?
We'd have to go back and check, because we've got,
Well, here's the reason I raise it.
yeah.
Is I heard that was happening, and then I heard it got canceled, and I wasn't clear. They said it was a contract with you, but what you're saying is the testing for the schools is sometimes contracted by you, sometimes contracted by the local health department, sometimes contracted by the local school system?
Yeah,
So-
go ahead,
Yep.
Assistant Secretary Yee.
Good afternoon, Webster Yee with the Maryland Department of Health. Senator Rosapep, there's two programs. There's a screening testing and there's a diagnostic testing program. So with the screening testing program, the initial set of contracts were put out before the Board of Public Works in the fall, and the Board of Public Works approved it. I think what you're hearing about is there was a recent contract modification to adjust for utilization and usage back at one of the January Board of Public Works. So that included one of the vendors for the Baltimore City schools. So far, we've done about 1 million tests through the screening program and about 86,000 tests through the diagnostic program.
But we can talk about it offline. I really just kind of want to get up to speed on what's really going on with that. So thank you. Oh, reserves. This is something we, Secretary, you and I have talked about in the context of Delegate Peña-Melick and my legislation. Is, as you know, we ran out of tests in December. And what's the plan now? And again,
Yep.
budget-wise, I mean, to make sure that in the next surge, we don't have what we went through in this surge on tests.
Right. So we back up a step, and this is part of the sources and uses
Gotcha, yeah, makes sense.
process. We actually, over the last summer, we bought tests.
I know.
Because they're through Abbott, and we had a supply of tests. The challenge was that it wasn't enough, because, you know, as you
I
know,
know.
the people thought that, pandemic was over, and
Yep.
we bet against that. We
Yep.
said, no, it's not. And so we had tests, but it was very limited.
Right.
Then we went out, and as it was clear that this was a problem, the manufacturers ramped it up. We've bought so far 8.5 million tests. We've received 4.3 million, and we've delivered into the community 2.1 million tests. We're going to continue that process. And our priorities, for example, we're giving tests weekly to the nursing homes, and we're going to continue that. We're giving tests to the judiciary so they can operate. We're delivering tests to the local health departments so they can distribute them in the community. So what we're doing now is sizing that. What do we think it's going to be? And that gets into this hot, warm, cold.
Okay, all right. Again, if you could provide information on that
Yeah, we're
offline,
working on those
I mean,
numbers as we
I'd really
speak.
like to know what your reserve capacity plan is.
Yes,
You know,
yeah.
how much do you always want to have on hand?
Well, that's a classic inventory
Yeah, it's an
management
inventory
problem, and
management,
we're
yeah.
working as to
Okay,
what is
okay.
that number. You're exactly right.
That'd be great.
And Senator, if I could just briefly add in, and this is a question that Ms. Brandenburg is really working at, you know, we're trying to explore from the federal government side exactly how many tests we can keep on hand that will get federally reimbursed, because, you know, the feds don't want us to just stockpile, so we also need to make sure that.
They don't want you to stockpile?
They don't want us to stockpile. There is I think, a 60-day limit
Well,
on.
tell me about that. That's the first I heard of it.
It's FEMA Public Assistance. I'm happy to share the policy with you, but at this time, unless things change, FEMA Public Assistance will support a 60-day stockpile.
And then, Senator, if I may, just to clarify the Secretary's comments, the state has and has maintained laboratory service contracts for PCR testing. And there's no question that we have plenty of capacity in the state for PCR testing. What the Secretary is referring to was at-home type point-of-care testing, which is like a Binax box of 2 tests or something like that. And then we have separate contracts for what are called the Pro Kits, which are packs of 50 that we work with clinicians and the nursing homes to distribute. So there's actually 3 types of tests
Right.
involved.
Okay, we can pursue it offline. Thank you, Madam Chair.
Thank you, Senator. Thank you all for your questions. I just have one question/issue I wanted to bring up, Mr. Secretary. That's related to concerns that have been brought to me by some colleagues. And you know, there was recently an article about the Board of Public Works approval of the increased contract amount. Can you just speak to that for the record?
Sure, Madam Chair. Thank you for that question. We were grateful that the Board of Public Works approved our EY extension. And that contract had been at $47 million. And we are looking, again, over the horizon through January of next year to make sure we have resources in place. Those are not to exceed amounts. Obviously, if we don't use it all, you know, that we won't spend it all. And the 40 million additional, there's 25 for COVID that'll take us out through the end of the year, and 15 for the recovery from the network incident. They're helping us with all of the continuity of operations activities. Right now, we've got most of our functions are back up. We have over 450 plus functions within the department, and that are, you know, that were affected, and we've got most of them up or a workaround, and EY is helping us with that, and we are now reconnecting, so we've got a lot of reconnection activity with local health departments, with the health boards, within our internal functions. So they're going to be helping with that. So we wanted to have on the 25 million for EY, we wanted to make sure we had a long enough horizon to take us out. And, you know, we're also conscious of that next year's transition. We want to make sure we have resources in place so the new team, whoever that is got resources available and a plan that we can hand over.
Okay, so basically, if I hear you correctly, when I go back to my colleagues, my response is, you had an initial contact based on what you saw as the immediate need.
Correct.
The contract scope increased based on what you then learned was the need. And the
Correct.
new expansion is what you anticipate you will need based on what you're doing now and what you see in the foreseeable future. Is that a fair
correct.
characterization?
That's a fair characterization. Plus, we've added the network incident because that was unforeseen. You know, it was pretty despicable that, you know, the health department is being attacked in the middle of all this, but
Yeah.
we've managed to work our way through it.
That's what I was going to ask. Are we in pretty good shape as far as that's concerned at this point?
Yeah, and we're in reasonably good shape. We're recovering nicely. The good news is we've been working for over 5 years on making our systems more resilient. So in many of our systems were not touched. It's these 460 functions that were affected, and we're bringing them back online. So we were lucky, quite frankly.
Okay, fair enough. Thank you very much. Are there any additional questions for this panel? Thank you all so much for your time and your presentations. Colleagues, we have some testimony on your desk, and we do have some witnesses signed up on this budget. So we're going to hear from first Kevin Cullen. And just so you're on deck, our second witness will be Otis Brawley. So you can get ready, you're on deck. It's a little baseball analogy in the middle of February. Good afternoon.
Good afternoon, Madam Chairman, members of the subcommittee. Thank you for the opportunity to speak to you. I'm Kevin Cullen. I'm the director of the University of Maryland Marlene and Stewart Greenebaum Comprehensive Cancer Center. I'm here today to express my appreciation for the incredible support that our center has received through the history of the Cigarette Restitution Fund program, and to give you some brief highlights of some of the important milestones we have achieved this year with the support of the CRF. As outlined in the presentation which I submitted as testimony, the state's multi-pronged efforts in cancer control continue to pay off for the citizens of Maryland. Cancer mortality rates in our state continue to decline from first in the nation in 1990 to 32nd in the country today. We're very excited that the growth of the Cancer Center has been amplified by the new Rosalind and Leonard Stoller Center, which will break ground in April. This will be the new home for the Greenebaum Cancer Center and will provide state-of-the-art cancer care facilities for the citizens of Maryland for decades to come. This is supported by the state's capital budget and the most successful philanthropic campaign in the history of the University of Maryland, Baltimore and the University of Maryland Medical System. This past year, we were very pleased to receive a 5-year renewal of our designation from the National Cancer Institute as one of 51 comprehensive cancer centers in the United States, the highest designation provided by the NCI. This reflected our 5-fold increase in cancer research funding, which now totals $100 million a year, and it reflects our effort to involve the citizens of Maryland in clinical research. In the last 5 years, we enrolled nearly 10,000 patients on clinical trials, and remarkably, 56% of those trial participants were minorities and 48% underrepresented minorities. This is a testament of our commitment to the community. I also show an example of cutting-edge research going on at the center. Dr. Graham Woodworth is leading a team which has done a first-in-human clinical trial of a novel technology to treat brain cancer, and which we believe holds great promise. And I'll leave you with an anecdote about our efforts to involve the Cancer Center in training and outreach, which are key missions for the NCI. One of which we're particularly proud of is our Cure Scholars Program. This is the first program of its kind in the nation. It was funded by a grant from the National Cancer Institute, and it's now in its 6th year. This is a training program for middle school and now high school students in West Baltimore. 120 have participated so far, And they are mentored 3 times a week in STEM education by 150 volunteer mentors from the university campus. The first group of students who entered in the 6th grade are going to graduate from high school this year, and I'm very pleased to tell you that more than half have already received college acceptances. One student has received 18 college acceptances, another 8 they have received acceptances at 8 of the University System of Maryland universities, and one is currently under consideration for a full scholarship at College Park. So these are just examples of what we have been able to accomplish with the support you have given us through the Cigarette Restitution Fund, and on behalf of everyone at the Greenbaum Cancer Center, and on behalf of the citizens of Maryland, I want you to know how much we deeply appreciate it.
Thank you. Thank you so much for your presentation slide deck and your testimony. Are there any questions from subcommittee members? Okay, thank you very much.
Thank you.
All right, we'll move to Otis Brawley and followed by William Nelson. Or is that both of you?
That's both of us.
Okay.
We can save you some time, and I have to say, Madam Chair, it is indeed a distinct pleasure to be with you in person this year, as you mentioned at the outset. And we're here also, like our friend Kevin Cullen, to thank the subcommittee and the legislature for the strong and sustained support for the Cigarette Restitution Fund over the years. And this, at Johns Hopkins, supporting cancer research, continues to deliver impactful discoveries, exciting commercial opportunities, and meaningful improvements in cancer screening, detection, diagnosis, and treatment that benefit, of course, Marylanders, but everyone in the country. This year, we're clearly supporting the governor's proposed budget for a $2.6 million allotment for cancer research at Johns Hopkins through the CRF, but also separately seeking support for a one-time investment of $2.5 million from the general funds mechanism to support the purchase of high-end mass spectrometers. These are instruments that are capable of assessing an individual's exposure to carcinogens and tobacco smoke and air pollutants and the like from a blood test. And of course, there are instruments throughout the state that monitor what's in the air, but it doesn't tell you what an individual has been exposed to. And our hope is by doing research around this problem, we can tailor an individual's risk for cancer to target them for specific screening and other intervention and mitigation processes. Our intent is to house this equipment in our shared resources, which is a program we share with the University of Maryland, so it'll be available to all the researchers who might need to use it at Johns Hopkins and at the University of Maryland. And of course, it's difficult to completely assess all the benefits of the Cigarette Restitution Fund program over the years, but it is remarkable to think that in 1991, before we started on this journey, Maryland was the worst state for cancer mortality in the whole country. We're now down to 34th. Hopefully, we're continuing to plummet. And one of the reasons I brought Dr. Otis Brawley along this year is some of the adaptations that we've had to make in healthcare in the state and throughout the country related to COVID-19 threatened to undermine a little bit of this progress because we had to put a kibosh on screening briefly and these kinds of things. And Otis Brawley was overseeing an expansion and refinement of our community outreach and engagement for the purpose of risk reduction and whatnot. Very timely, because I think we're going to be able to leverage that to get back on track. Otis.
Yes. Thank you. It's a privilege to be able to address you today. The COVID pandemic has led to a period of time where there's been a decrease in screening, and a number of health behaviors have changed, such as increase in caloric consumption, which leads to obesity. And many people don't realize the number 2 cause of cancer in the United States is energy imbalance, consumption of too much energy, not enough exercise, and storing too much energy. We call that obesity. We're very concerned that these changes in health behaviors and the decrease in screening is ultimately going to lead to increased numbers of cancers and increased numbers of advanced cancers. And with that in mind, we have started programs to put community health educators throughout the state to work with healthcare providers and work with others to try to promote changes in health behaviors. We do have to overcome the screening backlog, but we also need to invest in prevention and risk reduction at the same time. Again, thank you for the opportunity to talk to you.
Thank you very much. Any questions from the subcommittee members? Thank you very much for your presentation and your work.
Thank you, ma'am.
Thank you,
All
ma'am.
right, good afternoon. We're going to now hear from Nathaniel Richardson. And Kristen, do you want to come up, Kristen Bryce? Yes. So we thank them for their presentation on cancer. I'll tell you, just in my county alone, in my circle, I don't know a single family that has not been impacted by cancer in some way. So we've got to continue to support those programs. All right, Mr. Richardson, it's good to see you in person.
Yes,
And, well, I saw you in Prince George's County during the pandemic masked and at a distance, but it's good to see you in Annapolis.
same here, thank you.
Thank you, Madam Chair. I don't think he's taken his mask off for 2 years, I'm not sure.
It's good to have eyes on you as well, Kristen.
It's good to see you. It's
Yeah.
good to see all of you. Thank you, Madam Chair. Good afternoon, Chair Griffith and members of the committee. For the record, my name is Kristen Jones-Bryson. I'm the Chief External Affairs Officer for the University of Maryland Medical System. I want to start by thanking Ms. Wagner for her analysis and her recommendation. We are here today to testify in favor of the operating grant for Capital Region Health in Prince George's County. I'm going to try to go really quickly here. I know you guys have had already a long day, but I do want to introduce the person who is here at the table with me. For those of you who do not already know him, Nat Richardson is the president and CEO of Capital Region Health. He joined the University of Maryland Medical System in May of 2020 in the throes of the pandemic. Before that, he led the Huntsville Hospital Health System in Alabama. I think he's been in healthcare for 34 years because he started working when he was 10. And I'll just say one thing to the committee on a personal note, that I think says a lot about who Mr. Richardson is. If you're ever in his hospital or one of his facilities, you are just as likely to see him transporting patients or helping his EVS staff do the job that they need to do as you are behind a desk any day of the week. And I don't think he works less than 24/7. So it's a privilege to serve with him, and thank you for having us today.
Absolutely, thank you.
Well, good afternoon, Madam Chair and subcommittee members, and thank you for not only this moment to present before you and share some information about the transformation of healthcare in Prince George's County, but I want to thank you for the support you have continued to give Capital Region Medical System, formerly Prince George's Hospital Center. I certainly understand the investments and the ask of this committee. I've sat here and I've heard the ask throughout this day, so I don't take the ask and this support that you have given us. I take it very seriously, and I don't take it for granted. I am a individual that was raised by a Navy man and Army mom. I assure you there was no accountability in my house. But I take my job very serious, and I take healthcare very serious. Kristen shorted me by 2 years. I have been in healthcare 36 years, and I'm approaching my 37th year in healthcare, and have had a great career serving throughout those 36 years. But this grant that you all provide, I want to share who is the University of Maryland Capital Region Medical Center. We have 5 campuses. Those campuses are located in Laurel, Bowie. We have a clinic in Suitland, National Harbor Clinic, and we opened up the Largo Medical Center June 12th, 2021. So those are the access points for Prince Georgians across the county. When I got there 20 months ago, one of the things I said was we really need a strategic plan around these access points. Just because we have healthcare facilities located across the county, what are they doing to move the healthcare needle within the county? So the team and I, Kristen, as well as the executive team that I work with, Brad here, Seaman, who's now on the team permanently as our VP of External Affairs, looked at each of those access centers, those health facilities and campuses to determine what services were they providing. I personally read the health report in Prince George's County and looked at the disease challenges that we have. And when you talk about heart and vascular disease, cancer, when you talk about prostate cancer, when you talk about neurosciences, and you think about women's health, That has been a challenge in our county. It's been on pretty much every health report that has been put out over the last 3 or 4 years. But what have we done about it? What are we doing about those health reports versus reading them every year? So as we evaluated each of those campuses, we looked at those specific 5 issues in Prince George's to make sure that those campuses could deliver those services across the county so that our residents would have access to each of those specific campuses and make sure that those services were meeting those needs. You may or may not know that Capital Region Medical Center is the 2nd busiest trauma center in the state of Maryland. It's also the only trauma center in Prince George's County. And that comes with a large cost to run a trauma center. I will tell you that last year we invested $12 million in subsidies to run the trauma center in Prince George's. Something else you may not be aware of is that in Prince George's County, when you look at the type of traumas that we have, the national average for penetrating trauma, any gunshot wounds or stab wounds that actually penetrate the surface of the body, it's about 8 to 10%. At Capital Region Medical Center, we run double, 19 to 20% penetrating wounds. We get a lot from DC. We get, of course, a lot of gunshot wounds within our county. So that's just an interesting statistic to talk about the investment in trauma and why that's so important. We also, in the last 24 months, with all of the challenges some of my colleagues in this room who have presented before me have shared, is that when you think about the investments in resources, how we have been short with nurses, the cost of the pandemic by the agency costs, that a year or 2 ago you could get an agency nurse for $65 an hour. It's costing $200 an hour today. And that cost has continued to present a challenge for many organizations, not just ours, but we can't allow those costs to get us off focus on what our vision and mission is. And that is to make sure that we transform that healthcare. But we've invested $14 to $16 million in permanent costs at Capital Region specifically in nursing salaries, making sure that we're at market price, making sure that the dollars that we invest would retain the nurses, and that's the most important point now is retention, because there's not a large pool of nurses across the state, across the nation that you can get to come into your organization. So we have to focus on retention. What are some of the things we've been doing with retention? We have a serenity room in the hospital where our team members can go and just relax, and if they want to meditate, they can go in those rooms. Myself and the executive team, we have started executive rounding to make sure that we're asking our team members, how are you doing today? Not how much work are you doing? We're not there to monitor the productivity. We're there to ask them questions about their well-being and their mental health. So we walk around and we make sure that we have those connections with our team members. We also have an employee assistance program that they can call if they're struggling with anything in life. And that's a service that's provided 24/7, and it has been utilized by a lot of our team members. So those are important. So that strategic plan. Historically, Prince George's Hospital Center, or now Capital Region Medical Center, was a critical access trauma and safety net hospital. Those were the services that it focused on. The team and I developed the strategic plan to say we need to be a comprehensive medical center with all dynamic services, and we don't need our residents leaving out of Prince George's County to go elsewhere for health care, to DC, to Virginia, or otherwise. So this plan included services that we would add above and beyond trauma, critical care, and being a safety net hospital. Those services were women's health, cancer, neurology, heart and vascular, and orthopedics. Those are services that we have decided to add in the last couple of years that were not a part of our programs at Capital Region Medical Center. We have hired a breast surgeon to date. In the last 21 months since I've been there, we've hired a breast surgeon. We have 2 breast surgeons, one that was there. We've added a second breast surgeon. We have a structural heart physician, invasive cardiologist that we've added to the program. We've hired 2 obstetricians, 1 urogynecologist, And something else this committee, I think, is important when you talk about investments that some organizations have and do not have. Let's talk about maternal fetal medicine. 50% of our moms at Capital Region Medical Center are high-risk mothers. So you've got to have a fetal medicine physician to be able to provide care to the mother and the baby. And those physicians can be very expensive. So those are investments that we have made at Capital Region Medical Center as well. You talk about accountability. Within our 5-year strategic plan, we have a 3-year performance improvement plan. That performance improvement plan says, okay, Nat, we've given you, we're supporting you with this $10 million a year. These are the programs that you're going to support, that will support that $10 million. But how are you holding yourself accountable as an organization to become efficient, to become a self-sustaining organization? And some of the things that we have done around efficiency is reducing our length of stay, making sure readmissions are down so that we can get patients in and out of the hospital. We have reduced our overhead by the tune of $5 million, and that started back in January of this year. We have also made sure that we've looked at our operational models to ensure that every structure within those operational models are efficient. And what I mean when I say efficient, in the emergency department, the way we designed it, how you can get patients in and out of the rooms. We've had a big challenge with boarders in the emergency department, so how do you get throughput in your ED so that you get the boarders upstairs in the patient rooms where they need to be, and making sure that we can utilize all 41 bays in the emergency department. We continue to work with our specialists. We've got to also invest in primary care because we have great specialists, but they need primary care physicians to work directly with them so that these patients have a referral source when they need specialty type services within our organization. The denial management is huge, and that's, again, making sure that we're collecting every dollar that we can within the hospital so that we don't have a high level of denials and we're not having to continue to ask because we've not done our job on denials. So, Madam Chair and Committee, those are just some of the things we have done here at Capital Region. That is the change that's different in Capital Region than historically, because we believe that we can deliver great care in Prince George's County. We want to be a provider of choice and not just a critical care, and as I stated, trauma and safety net hospital. So a lot of investments that we are making. One of the most proud investments, Madam Chair, you are aware of, is our transition into a comprehensive cancer center. So we have started the process on developing a regional cancer center at the Largo campus. We're very proud of that, and that will certainly prevent our citizens from having to go to D.C. and other states for cancer care. We're partnering with other facilities on sickle cell. That's a major problem in Maryland, and I don't know if you know these statistics. Out of the 5,000 cases in the state of Maryland, 40% of that 5,000 are Prince George's residents. The problem with sickle cell is when they get to the age of 18, 19, they don't have that transition into an adult sickle cell program. So we're partnering with children's and other facilities to try to determine how do we have a bridge between being a pediatric sickle cell patient and transitioning into adult sickle cell. So these are all of the investments that we're making in the organization, and that's what this funding is supporting. I'll stop there and answer any questions that the committee may have with these investments.
Thank you very much. Are there questions from the subcommittee? Senator Rosapek.
Hi, very good to see you.
You too, sir.
I'm trying to get my head around the math. These expansions, you're talking these 5 new programs, that is what you're spending the $10 million a year that you're getting from the state on, or?
No, so
I'm
the
missing
$10 million, as you know, Senator, has been in place for 3 years.
I know.
And they've supported the organization under trauma, critical care, as well as safety net. We've added these programs in the last year, and that money will also help support the growth of the organization into a comprehensive medical center.
So you are using some of the $10 million
Yes.
to create these new programs?
Yes, sir.
Okay. Do you have financial models for each of these programs in terms of, I mean, I presume you lose money when you start and you make money over the long run. I presume
do.
that's why you're doing it. Can you share with us, not today, obviously, but just share with us the financial model so we can kind of see the risk reward on those programs? If you could
Yes.
send that to us, that'd be great.
Okay.
Thank you. Thank you, Madam Chair.
Thank you. Are there any other questions for this panel? Okay, thank you very much. Always good to see you. And I was just thinking, Mr. Richardson, I actually first met you at a Healthcare Heroes Appreciation event in Cheverly, and then
That's
later
right.
Senator Rosapep and I saw you again at the Healthcare Heroes Appreciation event at Laurel. So thank you for putting yourself in a position to celebrate those folks who are doing the work, and you and your team, along with all of our healthcare providers and all of our institutions across the state. We've got to get creative about finding ways to say thank you, and it's, some of it's monetary, and we're certainly going to work with our hospitals to do the best that we can to help there, but also just saying thank you and being there for them is important. So thank you for that.
Thank you. It's our pleasure to serve.
All righty.
Thank you.
All right, colleagues, we have our last budget before us, which is the Maryland Department of Health Administration budget. We're going to welcome back up Analyst Andrew Garrison, who's going to present this budget in just a moment, and then we'll hear from the Secretary and his team again. So good afternoon, Mr. Garrison. Good to see you.
Good to see you again, Madam Chair, members of the subcommittee. In front of y'all today, we have the Health Department Administration budget, and I will say that administration is actually a bit of a misnomer here because we also have all of the health facilities that the state has now under this budget as well. So we have a total of 12 facilities. We have now included the DDA facilities in this analysis as well. So a lot of the dollars that we see are actually going to be related to those state health facilities, and we're going to talk about that, as well as a lot of the state's, the health department's personnel is in this budget. And so we focus a lot on that here. But the first thing I did want to highlight is with the personnel component of this budget and those state health facilities, what we've done here in Exhibit 1 is we've looked at the staff safety as measured by resident on staff assaults is something that's reported relatively similarly by both the DDA facilities and the BHA facilities. And what I want to highlight is the DDA facilities are on balance a little bit lower in terms of the rate and as well as number when compared to some of their counterparts at the BH side of things. Those are the three dots towards the bottom there, Holly, Potomac, and Set. We do have the highest rate at Perkins, which isn't surprising given the nature of that facility, but it is still below the rate at which the department sets as a goal. However, the department reports patient safety differently between the two facilities. One is a patient injury rate and the other is a patient-on-patient assault. And so what we have a recommendation for here in front of you is committee narrative requesting the department kind of do two things for us. One, really look at what is the best way to report on safety for both the staff and the patients at our state health facilities, and then also then to include that reporting and from those recommendations into future MFR and other data that they provide to us to really allow us to compare across the different health facilities that we have here in the state. The other thing I would like to highlight is, before we get into the budget section, is around the court-ordered placements. And so this budget as well, with the state health facilities responsible for court-ordered placements, particularly those who are either not criminally responsible, those are the NCRs, or the incompetent to stand trial, that's IST, and placing those folks in a timely manner in our health facilities. And there's a few different places that they can end up. And there actually was a legislative mandate passed in 2018 to get those folks into facilities within a 10-day period. And we see that the department's been able to do that, was able to do that in 2019. However, in recent years, it's sort of trending in the opposite direction. What we'd like to see, of course, is an increase in average number of days for that cycling and then the number of patients admitted within that period. And so we do have a recommendation around adding budget bill language to restrict funds pending a report on the placement of these court-ordered individuals and steps that can be made to make legislative mandates for those placements in the state's hospital system. Moving into the budget section of the analysis, as I mentioned, Administrative is really only a small component of this budget. It's under about 20% is what we'd kind of consider traditional administrative expenses, with about 2/3 being state hospital employee expenses, and then that other 15% for the actual day-to-day operations of those state hospital facilities. Focusing in on the 20% that is the administrative component, that largest chunk there, that third under operations, a lot of that is shared services. So the Office of Human Resources is shared throughout the department. That's budgeted in there. Any sort of shared procurement is also budgeted in that section. We also do have some smaller offices to highlight. The Opioid Operational Command Center is now housed within this budget. The overarching hospital system, the kind of consolidation that really allows us to talk about all of the state health facilities in this one budget is budgeted here as well. The Office of Minority and Health Disparities. And then, although they are separate from the department and have their own line item in the state's budget, we are considering the new Inspector General for Health here as well. The largest changes that we see are related to personnel expenditures, as you would imagine, given where the funding is distributed. And so that's what we're going to spend a lot of the budget section talking about here. In particular, there was some impacts that we're starting to see from legislation that you all passed a few years ago. Chapters 572 and 576 2020 pertained to the compensation of largely the folks at the state hospitals, and we see that was a $35 million increase. We are starting to see that now in fiscal 2022, and that funding continues into 23. The other things that have been added to this budget for our compensation for the state employees at those health facilities is budgeting overtime. So there's a overtime deficiency that was added to this budget that also carries over into 23. A regular earnings increase of about $8 million. That's also, again, related to y'all's legislative action from 2 years ago. And then there are additionally some statewide salary enhancements that are currently not yet reflected in this budget. However, those the governor's negotiated increases, and so we're reflecting those fiscal 23 ones there as well. In particular, focusing in on those chapters 572 and 576, what we've done here is we've looked at how that's distributed throughout the different health facilities. And of course, this legislation had kind of different impacts depending on the nature of the facility. So Perkins saw the largest increase related to these works because a lot of those enhancements were based on Perkins or on the forensic population or increasing the number of security tenant ratios. And so all of that does affect Perkins. The other facilities that are receiving more, a disproportionate share of these enhancements are the regional BHAs, as well as some of the DDA facilities who have that higher forensic share of individuals. And so the staffing there are planning to be compensated accordingly to some of the patient mix that we're seeing, again, under that legislation. To briefly talk about the overtime expenditures, as I mentioned, there was a deficiency in fiscal 2022, and this actually brings up the department to and these budgets to roughly where we would expect. DLS has previously pointed out that overtime has been perhaps under budgeted, and it's usually an area that does receive a lot of funding at fiscal year closeout. And so the 2022 deficiency and then that funding being carried into 23 reflects closer to what we would ultimately expect when it comes to overtime expenditures, particularly at our health facilities. Briefly, there is actually a net decrease in the positions that are within these hospitals. The department in general overall doesn't decrease positions, but rather they're moved around and shuffled, and they are shuffled outside of some of the facilities here. And we do see that that's not necessarily uniform throughout some of the facilities. However, it does net out to be a modest decrease of, I believe, about 13.5 positions total when looking at these facilities. And we also do show you vacancy rates as well. Here for this budget. Again, this is the largest share of the department's employee complement is here. And a few things to put a pin in particular is the DDA facilities, Holly, Set, and Potomac, the fourth through second to last on the screen there, all have a relatively high vacancy rate, and that's going to be interesting when we look at some of the other analysis that we've done here throughout. But it's not necessarily uniform that the facilities have a higher vacancy rate than the administrative offices. We do see the executive direction also being kind of above the average that we've pulled in here. And you all might recall from the health department overview, we did a look at kind of cohorting the health department's staff. And we've done that here again, but we've done it just with the folks who are budgeted in the administration budget, so the kind of broader, the big headquarters administration, as well as all of our state facility employees. And so what we have here on Exhibit 13 is the current cohort, so as of January 2022, how long they've been with the department. And as you can see, the blue bar and lines are the folks who work in the more administrative functions, and the red is the folks in the facilities. And we have the administrative staff being slightly more tenured, which is kind of what you'd expect, particularly if we look at folks who started their state service in the 90s to early aughts, with the folks at the state facilities being a little bit less tenured. And then the other thing we did is, because we were able to take this one cohort and we looked then back at the 2020 cohort, so the pre-pandemic cohort, and we compared the employee identification numbers between those two areas, and to try to find out who was no longer with the department. We kind of colloquially call that quits throughout this analysis, but of course, anyone could have left for any number of reasons. But in particular, what we're doing here in Exhibit 14 is we're looking at that quits rate, so folks who were no longer with the state in 2022 when we looked again at that cohort, relative to the 2020 amount. And what I do want to highlight is we see the DDA hospitals having a relatively higher quits rate, which is pretty consistent with what we saw in the vacancy data as well, where they were higher on that vacancy rate. Again, particularly with the healthcare professionals, a lot of those folks who are working in our hospitals on a day-to-day basis. Using that same methodology to find the number of folks and the individuals who left state service during the pandemic, we see again that it was, and here's the same kind of proportional analysis. And what we see is that the folks who left from the facility side were broadly less tenured than the folks who left from an administrative standpoint. If we kind of compare the red and the blue lines in front of you, you look and you see about half of anyone who left during the pandemic was with the state for 5 years or fewer, roughly, where that share on the, for the administrative side is closer to maybe 10 years or so of state service. And we do see then, conversely, that anyone who left state service during the pandemic on the administrative side of things was likely a little bit more tenured, might have started, again, kind of in the 90s or aughts, and, may have been close enough to retirement that, but it was a time that made sense to leave. And so kind of taking all this in mind, DLS has a set of recommendations here around budget bill language, restricting funds pending a report on staffing. This is actually the language that we've ultimately written is similar to something that you all requested last year that is still outstanding. And additionally, we want them to consider the impact of some of these new legislative enhancements and salary increases and how that may have helped with retention, given that that does seem to be a problem with the state facilities. Additionally, I'm going to talk a little bit more about the facilities master plan when we have the capital budget in front of us. However, that does outline some changes to care delivery models and different hospitals that are going to be within operations in the near and medium term. And so we are also asking that recommendation for that budget bill language include consideration around how the health department's employees and employee alignment will align with what the plans are for the department in the future through that master plan. Really briefly, I do also want to touch on information technology and the network security incident. The major IT, most of the major IT programs are budgeted here in the health department's administrative budget. And on Exhibit 16, we see that with a few exceptions, some of the larger IT projects the department has been undertaking have essentially pushed any fiscal 23 funding out into the out years, and so there's more spending in 24 and 25 than was previously anticipated. And then overall project costs have largely gone up as well, with the exception of the cloud data center, which is actually spending less this year and seeming to get done quicker, which is encouraging. And on the network security incident, I will note that there was, I believe it was approved in the Board of Public Works this week, an additional $5.6 million in general funds for new equipment to address that. We've also kind of summarized the current status of that for you all as well. But that does conclude my presentation, and I'd be happy to take any questions.
Thank you very much. Are there any questions for the analyst? Okay, seeing none. Mr. Secretary, if you want to come back up and bring whoever you would like with you, we would be delighted to hear your response to Mr. Garrison's presentation.
Thank you, Madam Chair. Good afternoon, members of the subcommittee. For the record, my name is Dennis Schrader, Health Secretary, State of Maryland. And again, we thank the governor and the Budget Committee's support for our COVID-19 response efforts to date. We also thank the Department of Legislative Services budget analysts for the comprehensive and insightful discussion. As noted, we released our facilities master plan this fall, and the three-phase 20-year plan aligns with the Department of Health's projected patient care needs with healthcare services offered or provided by the department. It does enable us to begin the process of divesting facilities that are no longer operating, possibly using existing capacity that already exists inside of Maryland for some of our needs, and to build, where appropriate, new state-of-the-art facilities and properly plan so that we can continue to provide Marylanders the level of health care they deserve and expect today as well as into the future. As was mentioned, there's three phases. Phase one, which is going to occur from 2022 to 2026, focuses on divesting three closed facilities: Crownsville Hospital Center in Anne Arundel County, the Regional Institute for Children and Adolescents in Southern Maryland, which is in Prince George's County, and Upper Shore Community Mental Health Center in Kent County, and begin planning for Spring Grove Hospital Center divestiture. Phase two, from 2027 to 2032, is focused on constructing a new facility for children and a secure evaluation therapeutic center facility in the Central Maryland region, and constructing a replacement patient building at the Springfield Hospital Center in Sykesville. And then the last phase, which will occur from 2032 to 2041 and is projected to include renovating the Holly Center, integrating MDH facility patients with community providers where appropriate, and developing strategic partnerships to transition services currently provided at the Potomac Center and finalized for Spring Grove Hospital Center to healthcare and community providers. And I will mention that as far as Spring Grove goes, we are already beginning to have discussions with Central Maryland providers that might be interested in working with us, because those processes take a while to develop and proceed with. Our goal through this ongoing process is to finalize a capital program that guides us through the rejuvenation of our facilities, and importantly is a planning document that will evolve over the 20 years. Of course, our other objective is to minimize to the state capital expenditures by being smart about how we go about this planning. I'll now turn it over to our Deputy Secretary for Operations, Chief Chowdhury, for a brief summary of our written response, and we'll be happy to take questions after. Again, we have Emily Brandenburg, our CFO, Nick Napolitano, Brian Morose, the Director of our Healthcare Operations in the state, and Will Andalara and Webster Yee. So I'll turn it over to Atif.
Great. Thank you, Mr. Secretary. Madam Chair, Vice Chair Rosapap, members of the subcommittee, for the record, my name is Atif Chaudhry, Deputy Secretary of Operations for MDH. I'm happy to provide an overview of our written responses you have before you. With regard to the request for a report on patient and staff safety, we concur with the DLS recommendation and want to reiterate that the safety of patients and staff are our highest concern and priority. With regard to the recommendation to restrict funds pending a report on placement of court-ordered IST and NCR admissions, we respectfully disagree. We believe this analysis should be viewed in the bigger picture lens of reduced court operations, healthcare staffing shortages nationwide, and the need to protect patients and staff from COVID-19 outbreaks. We have been working very, very closely with the judiciary over the past 2 years to carefully manage patient admissions and discharges. We have held steady at an average admission cycle time of 17 days for the vast majority of 2021, and had the same cycle time of 17 days during 2020. It's important to note that in 2021, we received over 150 more commitment orders than we did in 2020. Also, for comparison's sake, in 2019, prior to the COVID-19 pandemic, the average admission cycle time was only 8 days. If asked, we believe the judiciary would agree with us that we are all working together to manage this situation and ensure that individuals receive appropriate clinical care. We have worked with the judiciary to help keep the courts open, including distributing over 250,000 KN95 masks and 99,000 point-of-care tests to date. In addition, we are very pleased to partner with the courts to provide vaccination clinics at various courthouses for both staff and visitors. In 2021, we opened 2 new inpatient psychiatric units for a total of 40 additional new beds. And we've also taken the initiative to repurpose over 50 vacant merit positions to staff these new units. MDH typically discharges to step-down placements in the community. Community providers are also dealing with the same issues of COVID outbreaks, healthcare, staffing shortages, which have resulted in a reduced number of beds in the community. We have worked very closely with the Behavioral Health Administration within MDH to ensure community provider capacity to provide lower-level clinical acuity services so we can discharge patients safely from MDH facilities and into the community. The inability to discharge patients hinders our ability to admit patients on our wait list. With regard to the recommendation to restrict funds pending a report on staffing at MDH facilities, we respectfully disagree. Healthcare staffing is a challenge nationwide, and any comparisons right now would lead to misleading conclusions. As directed by chapters 572 and 576 of 2020, MDH has promoted existing staff and recruited new staff into security attendant classifications to meet the required staffing ratios in the applicable MDH healthcare system facilities. We continue to recruit for these positions through various initiatives, including online postings, local hosted job fairs, and career fairs. We've also implemented 3 12-hour shifts for nursing staff authorized by Chapter 327 of 2021, and we thank Senator Eckert for her support and leadership in getting that legislation passed. We also offered COVID-19 response pay for direct care workers, and fiscal year 2023, the allowance allows for a 1-grade annual salary review step increase for over 100 classification of nursing positions. With regard to the impact of the facilities master plan, Secretary Schrader provided a big picture view of the implications of the plan. And for more information, please see our written response and also the plan details itself. With regard to the master plan, we wanted to reiterate that the plan is a planning document that will continue to evolve over the 20 years it covers. MDH will work with employees and unions to address any impact that the master plan has on employees. And it's also important to note that we will work diligently to ensure that the impact to staff is as minimal as possible. We've also developed a communication strategy to ensure that we are working to provide updates and next steps that are communicated regularly with staff, and also give them an opportunity to ask questions about this long-term planning process. This concludes our overview of our written response, and we are happy to answer any questions you may have.
Thank you so much for your response. I'm just going to jump in since you just were on the facilities master plan piece and refer back to the analyst presentation on page 23 of Mr. Garrison's analysis. And you kind of started talking about a couple of the points that I wanted to highlight. One, as you know, in every budget hearing, I think this session, I've been talking about recruitment, retention, and taking care of the morale of employees. And to me, these two issues are kind of interrelated on page 23 of the analysis. And, you know, I appreciate your mentioning that there will be communication with the employees, you'll communicate strategies, but I will tell you, I've heard on numerous occasions concerns about the facilities master plan from employees, and certainly would love to hear from you in response, more about how you intend to align state employees with the master plan. Because I hear you saying you're going to communicate and share strategies, but it seems like we need to have kind of a two-way conversation at some point. Can either of you speak to those?
Yeah, if I might, Madam Chair, we, of course, 20 years is a long time. We have just started the development of an implementation strategy. We are, I think have announced publicly that we plan to leave Spring Grove. So we are working with the, but those facilities will be distributed within the Central Maryland area, and we have just started conversations. One of the things that we have committed to the HSCRC is that we would avoid building new construction if there was excess capacity. So we are just starting to explore that. So we're going to have a number of ideas about how to do this. And as those ideas become firm, then we'll start having conversations. But we're not there yet. It's only been 4 or 5 months since this has been announced. So we are definitely going to be engaging employees as some of these plans move from just general concepts to more project thinking. So and of course, our first priority right now, as it says, as Mr. Chaudhary mentioned, we want to divest ourselves of the properties that are non-operational at this moment. We've put in a clearinghouse letter on Anne Arundel County they've made a claim on that property, and we are working through those details. And then, of course, we're talking to Kent County, and we have not started talking yet, I don't think, to Prince George's, although I think we may have had 1 or 2 conversations. So that's our number 1 priority, get those, because those properties are requiring us to use resources that take away from our mission. So we want to get out from underneath those properties. In terms of Spring Grove, we're looking at how we might exit that property, but that'll take probably 10 years before we have all those solutions in place. I will say one thing that we're doing that is an early action at Spring Grove is as we are looking to leave 201 West Preston in our RFP that DGS has on the street as we speak, we are planning to move the BHA headquarters from Spring Grove to consolidate with the MDH in the downtown location that's selected by DGS. So that's an early action that we know is going to happen, and we are talking to staff about that. And as we get closer, I think the RFP closes in the spring, and the actual selection will be probably next fall. And so as we get closer in, we'll be having those. But that really is more a geographical issue for headquarters staff rather than the operations of the facility. So we will definitely be continuing these conversations. And I think one of the things we wanted to assure staff is that some of these, we're not going to walk up one day in the next 3 weeks and say we're ready to leave. This is going to be a process that we're going to be talking about year over year. I won't be here when the real moves start, but we're beginning the planning process.
And I was just going to,
Go ahead.
Yeah. Sorry, Madam Chair, I just wanted to also add that we've also set up a website that lays out the master plan and some FAQs as well, very easy to understand for the general public as well as staff. We've also set up an email address, so if anyone has any questions, including staff, they can send in emails to a centralized location for a response. We've also issued memos to staff outlining what to expect coming forward, and our CEOs and healthcare leadership have been engaging with staff to let them know that here's what to expect, here's a copy of the plan. Please feel free to reach out and we can talk through this as we go forward. So it's constant communication and coordination with staff on site.
Thank you. No, I appreciate that, and the email address at least provides some two-way communication opportunity. I just want to encourage ongoing engagement, because as was first presented to us, the plan was a working document, but I think the impression when it hit the street was, this is what's going down and this is how it's happening. So just wanted to put some emphasis there. Are there any other questions from the subcommittee members? Okay, seeing none, we'll move to some witnesses who've signed up on this budget. Thank you so much for your presentation.
Thank you, Madam Chair.
We have signed up Carrie Elliott, and then on deck, we will have Lance Kilpatrick and Brian Leach. So, you can come on down. As they're coming, I just want to thank the subcommittee members. I think we've been sitting since 9 a.m. in our, without break, so thank you all. Good afternoon.
Good afternoon. Thank you, Madam Chairman. My name is Carrie Elliott. I work at Deer's Head Hospital Center in Salisbury, Maryland. In September of 2021, the master plan was proposed to close 2 states' long-term care facilities in the next 5 years. They are Deer's Head Hospital Center and Western Maryland Hospital Center. Each of these facilities have provided excellent care during this pandemic. At Deer's Head, we were able to contain the virus to only 11 residents on 1 floor with 1 hospitalization, and all are now symptom-free and still recovering. Since our residents are vulnerable, I believe the state should invest more in long-term care. Also, our state's general population is getting older and are in need of public services that the state offers. Putting these residents in a private facility would cost the state even more money since most are on Medicare. Deer's Head Hospital doesn't only care for local residents, but also houses an essential community business called Coastal Hospice. So not only would closing Deer's Head Hospital hurt the facility's residents in need, but would also hurt the entire community. And I do know firsthand what it's like to put somebody in a nursing home. I had to do that 2 years ago. And she's in a private facility. She's not in a state facility. I have to make sure, being a state employee, that she is well taken care of because they do not worry about their employees with the residents. The employee cares about the resident, but it's the management that's there that does not care. They only look at the bottom dollar. If they can work with less people, taking care of like one worker to 40 residents, you don't get the care that you get when you come to a state facility. When you're having about 1 GNA to like 5 or 6 residents, where you can actually put in more time one-on-one with somebody. And if closing Deer's Head or Western Maryland Hospital, Western Maryland Hospital, I think, also does ventilators, where people are on long-term ventilation to keep them alive. You close that one, where are them people going to go? Because there's not very many facilities that do ventilations. Deer's Head, we are more towards dementia people, the floor that I work on. And we have actually, during this pandemic, we have actually become their family because their family members have not been able to come in due to either we had an outbreak or them themselves don't want to expose their family member. So in Coastal Hospice, if you close it, where them people gonna go? Because most of them people over there, they're over there to pass away. And it's very, very hard to sit there and tell somebody, oh, well, we don't have a facility that we can put them in. They're gonna have to go home. Or they're gonna be in the hospital and pass away in the hospital. And most hospitals, once they let you know that they're gonna pass away within a certain amount of time, they try to go ahead and discharge them so that they can fill their bed again. Thank you.
Thank you for your testimony. Thanks for being here and for your patience, waiting to get a chance to speak. Okay, Mr. Kilpatrick.
Madam Chair, members of the subcommittee, thank you for the opportunity to speak today. For the record, my name is Lance Kilpatrick. I'm the Legislative and Political Director for AFSCME Council 3, which includes members across all the MDH facilities in Maryland. And I want to thank my member Carrie Elliott for driving all the way today to share her concern and personal experience regarding this. I just want to address 3 issues specifically in today's testimony. So first of all, we've talked about the 2041 master plan. To me, it's neither masterful nor planful. What it actually does is propose privatizing roughly half of the existing facilities under MDH, ignoring the needs of Marylanders like Carrie has so well illustrated. Instead of closing down and privatizing these, they should instead be investing capital dollars in enhancement of these facilities to provide for the capacity to battle public health crises of addiction, mental health, and long-term COVID. I don't believe anybody believes that we are getting younger as a society. I don't believe anybody believes that chronic morbidities have been addressed sufficiently to not need these facilities and that we can reduce these services. And yet that seems to me to be the path that MDH is going down. And yet providing services is dramatically hindered by the high amount of unfilled vacancies and retention issues. So as an example, 4 years ago in Springfield Hospital, they had almost 20 psychologists, which would be enough for roughly 1 psychologist to be assigned to every unit to do individual and group therapy. Today, they are down to only 4 psychologists. Patient care suffers because of understaffing. MDH should put more effort into recruiting and developing a pipeline for employment into the state hospitals. As a start, MDH could expand the direct care trainee program and psychologist intern programs. Finally, hardly anyone wants to work in a dangerous work environment. Laws enacted in 2020, has been referenced, sought to address many of these issues in terms of hiring security to meet the needs of the facilities. However, MDH has failed to meet the minimum security ratios set by the law. In fact, it's our estimation that MDH needs to fill and add between approximately 130 to 160 security attendants across the state to meet the required ratios. The fact that it is taking MDH so long to even begin to address this situation, we believe is grossly negligent. In conclusion, I would point out one fact that I think is illustrative of the larger picture that we have here. The Department of Corrections has the largest psychiatric facility in the state, in Pawtuxet. And they're about to build an 800-bed facility in Baltimore City. There are thousands of inmates within the Maryland correctional system that could and should instead be getting treatment from our mental health facilities. Prioritizing investment and enhancements within the Maryland Department of Health should be the strategy going forward, not reducing and privatizing services. I thank the subcommittee for its time.
Thank you very much. Are there any questions for this panel? Okay, again, thank you so much for your time and for your presentation. I think, Philip, that's all I have. It looks like we have heard from all of those who've signed up. So with that, we thank the analysts, we thank the agencies, we thank the staff, and thank you again, members, for hanging in here with us. That concludes our February 18th hearings. Have a great weekend.